Mic test 1 2. Microphone test 1 2. Mic test. Mic test 1 2. 2 2 1. Microphone test. Right. 1 2 2 2 1 microphone test. Test mic. Test mic. Test. Mic test. Mic test 1 2. Microphone test 1 2 2 2 1. Microphone test. Mic test 1 2. Mic. Fine. All right. All right. Test 1 2 2 2 1. Mic test. 2 2 1. Mic test. Mic test. 2 2 1. Mic. Right. Mic. 2 2 1. Okay.
University of Rwanda since a bit more than 10 years' time. At the moment, I'm the acting director of research and innovation at the college.
Good morning, everyone. Sorry, we are starting an hour late. Welcome to the Rwanda Research Symposium with the theme Evidence-Based Research Practices in the Field of Mental Health and Child Development. My name is Umwari Gloria, and I'm your MC for today, along with
Today's event of research symposium. we are going straight to take 1 minute of silence. Please, I would like to request everyone to stand on his seat and have that a minute of silence.
Thank you. Thank you. Without further ado, please allow me to welcome Professor Vincent Sezibera from the University of Rwanda to give us the welcome remarks. Thank you.
Good morning. Dear DG and representing the Minister and the Minister of Gender and Family Promotion, dear DVC academic, and also representing the VC, University of Rwanda, dear Principal, College of Medicine and Health Sciences, dear invited guests, all protocols observed. I want to welcome you on behalf of the Center for Mental Health organizing this one-day symposium, and also to be honored to have in this room different institutions, government and non-government organizations, very enthusiastic researchers in the domain of child development, child well-being, and child mental health. We are pleased today to have also with us colleagues from Sugira Muryango, which is a project by the College of Boston College, which is partnering with us to develop a number of activities, mainly research capacity building. And we hope with that partnership, we will be able to develop collaborative research projects that contribute to inform the policy making and develop evidence-based practices that develop also strategies aiming at the improvement either in policies but also in the practices that promote the child development and child mental health. Without further ado, I would like to mention that existing literature has demonstrated a significant relationship between the parenting and child development, and especially child mental health. Positive parenting improves significantly the child well-being. On the other side, negative parenting that include child neglect, child abuse, violence, domestic violence, child defilement, all these circumstances affect poorly the child well-being and child mental health. Today, presentations will be sharing with us evidences from research, but also lessons learned from different programs that are developed in the country. today we will also sending a call to researchers to explore that phenomenon and make sure we are able to contribute using the findings and results from the research efforts to inform policymaking and strategies. As I conclude these welcome remarks, I want to thank you all to have been able to reach this room and to take your time and share with us the knowledge and support this initiative, hoping that research can contribute to the Rwandans' life improvement. As we said, research for service. We hope and we wish the university will continue contributing a lot in this specific domain of child well-being, child development, and child mental health. Thank you, and you are welcome.
Thank you very much, Professor Vincent. We are going straight forward to welcome Professor Teresa Bentancur from Boston College it is a video presenting the remarks from our partners. Thank you.
Our symposium, Evidence-Based Research Practices in Mental Health and Child Development in Rwanda. This is our inaugural research symposium of 2021. And this is a collaboration between the University of Rwanda and the Research Program on Children in Adversity at the Boston College School of Social Work. My name is Teresa Betancourt. I'm Salem Professor in Global Practice at Boston College and also Director of the Research Program on Children in Adversity. So today we'll be focused in the symposium on the importance of child development. As we know, the early years of a child's life are very important for his or her health and well-being, lifelong learning, as well as issues of mental health. And we know that healthy development means that children of all abilities, including those with special healthcare needs, are able to grow up where their social, emotional, and educational needs are met across the life course. And some of the important factors that come into play are issues such as safety, freedom from harm and violence, positive parenting and stimulation, and also topics of health, promotion, nutrition, exercise, and hygiene. So we know from the Lancet series on child development that at that time, and that was an estimate from 2007, it was thought that over 200 million children under the age of 5 years were not fulfilling their full developmental potential. And we see that far too many of children who are categorized in this way of being at risk of underdevelopment are in sub-Saharan Africa. And welcome everyone to our symposium, Evidence-Based Research Practices in Mental Health and Child Development in Rwanda. This is our inaugural research symposium of 2021. And this is a collaboration between the University of Rwanda and the Research Program on Children in Adversity at the Boston College School of Social Work. My name is Teresa Betancourt. I'm Salem Professor in Global Practice at Boston College and also Director of the Research Program on Children in Adversity. So today we'll be focused in the symposium on the importance of child development. As we know, the early years of a child's life are very important for his or her health and well-being, lifelong learning, as well as issues of mental health. And we know that healthy development means that children of all abilities, including those with special healthcare needs, are able to grow up where their social, emotional, and educational needs are met across the life course. And some of the important factors that come into play are issues such as safety, freedom from harm and violence, positive parenting and stimulation, and also topics of health, promotion, nutrition, exercise, and hygiene. So we know from the Lancet series on child development that at that time, and that was an estimate from 2007, it was thought that over 200 million children under the age of 5 years were not fulfilling their full developmental potential. And we see that far too many of children who are categorized in this way of being at risk of underdevelopment are in sub-Saharan Africa. And this means that these are tremendous problems when it comes to thinking about nations moving forward and developing economically and socially. And so today's topic is so important. And we know that for any one child's development and mental health, we have to think about multiple interacting factors. So what we call in child development ontogenetic or individual level child factors, age, gender, temperament, intelligence, genetic history. But also we have to look at what's going on, as Yuri Bronfenbrenner and others termed, in the microsystem. And this is the context of caregiver relationships, attachment relationships, and the interactions between the child and the parent's environment. And then we can't stop there. We also have to think about the mesosystem, the exosystem, extended kinship networks, peer networks, the community, and the other places where children are spending time, including schools, neighborhoods, even the healthcare system. And then we also have to think about the macro system levels, the political context, the historical context, and the role of culture, cultural beliefs about reconciliation, healing when it comes to issues of violence, also topics when it comes to caregiving and parenting, such as gender and the role of mothers and fathers in their interactions with young children and supporting their healthy development. And so the University of Rwanda and Boston College have been in partnership for many years now. We've been working with Dr. Vincent Sezibera since 2007, where we began working on parenting interventions, a family strengthening intervention, which was originally funded by our National Institutes for Mental Health in the United States, that looked at promoting healthy parent-child relationships in the context of families affected by HIV and AIDS. And now we've continued this collaboration and partnership with each subsequent research study, moving not just into areas of mental health, but also looking at parenting in the context of child development, early childhood development, and how could we have an intervention that both promotes early childhood development and prevents violence. And this has been really exciting work, and I hope you'll get to hear about some of that today. In 2020, we received support from the Oak Foundation to launch an additional partnership focused on mutual learning and how together we can talk about capacity sharing and coming together around research on topics.
Honorable Minister of Gender and Family Promotion. The principal of the College of Medicine and Health Sciences, dear colleagues, university lecturers and professors present in this room, students present in this room, distinguished participants, those who are present in this room, and those who are attending this symposium virtually. All protocol observed. As the moderator said, my name is Dr. Emile Bienvenu. I'm the acting Deputy Vice Chancellor for Academic Affairs and Research, and I'm representing the Vice Chancellor in this symposium who couldn't join us because of other engagements. And she's representing Honorable Minister of Gender and Family Promotion, who couldn't join us because of other engagement. We are very, very honored to have you in this room. In fact, this is a sign of support of what we do at University of Rwanda in terms of the core business of the University of Rwanda, in terms of teaching and learning, research and research dissemination, but also service to community. Your presence in this room have made it this morning for the Rwanda Research Symposium, having the theme mental health and child development. Universal Rwanda supports very much evidence-based practices like these times as we are confronted by effects brought about the pandemic of COVID-19. Universal Rwanda, through the different research centers, has supported the evidence-based practices, and Universal Rwanda will continue to give high priority to research, innovation, and entrepreneurship as part of achieving its goal for sustainable development and contributing to communities through its research, but also by producing graduates ready to provide solutions to challenges faced by communities. We cannot achieve this alone. That is the reason why Universal Rwanda values very much partnerships. There is no doubt that cooperation and partnership are fundamental if we are to achieve this goal. We appreciate our partners at Boston College who have joined us in this journey of strengthening capacity of our researchers in Rwanda, but mostly at University of Rwanda. We believe that this is our responsibility to contribute to the community challenges, and no doubt that child mental health are growing concerns, and yet a gap between university and the community partnerships exists. This symposium actually offers an opportunity for both Universal Rwanda researchers to bridge this gap. I would like to take this opportunity to express my sincere gratitude and appreciation to all organizations, international and local, who have joined us today as we bridge this gap. And the university commits to strengthen this partnership, especially in the field of mental health and child development. I would like to express the Universal Rwanda sincere appreciation to all the funders, especially to Professor Teresa Betancourt and his entire team for the continued support and the guidance to our researchers in the field of mental health. A sincere gratitude also goes to the College of Medicine and Health Sciences and its leadership, especially the principal of the college who is present with us, but also the entire team involved in mental health research for the efforts deployed to organize successfully this symposium. On this note, I would like to stop here and welcome Dr. Anita Asimwe to give the opening remarks. You're welcome, Doctor.
Thank you very much. Deputy Vice Chancellor, the Principal of the College of Medicine and Health Sciences, Prof. Sezvera, the Director of the Research Program, the Director of the Center of Mental Health, and colleagues joining from Boston, specifically the Director of Research Program and on Children and Adversity at the Boston College, distinguished ladies and gentlemen. Let me start off by saying good morning. Good morning to you all. I am greatly pleased and honored to be here on behalf of the Honorable Minister of Gender and Family Promotion, and much more so pleased to be with you to discuss mental health, child development, and programs surrounding the promotion of families from a research perspective. As you might be knowing, the government of Rwanda recognizes the family as a cornerstone for our country, for the development of our country, and as such puts a lot of emphasis on its importance and its development. For its protection and promotion, I mean the family's protection and promotion, different mechanisms and institutions have been established, really with an aim to seek the fulfillment and abundance of our family. Our government has also, in addition to establishing such mechanisms and institutions, also continued to nurture strong collaborations and partnership with non-government organizations, with the private sector, with religious-based organizations, to mention a few, because we appreciate that the journey to ensure that the family is promoted and protected is not something that the government would do by itself, and as such, puts in all the effort for such partnerships to happen. As we like to say in the Ministry of Gender and Family Promotion, the aim for our government is to ensure that we have stable and resilient families. Stable and resilient families takes quite a lot, but stable and resilient families is what we need if the family is going to truly be a cornerstone for our country. The commitment of our government to advance the family and its members is well captured and well enshrined in our Constitution. I'll mention just a few articles in there. I'll start off with Article 18 of our Constitution, which clearly states that the natural foundation of the Rwandan society is the family, and it has to be protected by the state. That is a very important article that guides us at what we do. Before I get to the second article that I would like to refer to, looking at this article, it goes ahead to show that both parents of a child not only have the right, but also have the responsibility to raise their children. And the state puts in place appropriate legislation, appropriate organs for protection of the family in order to ensure that the family will flourish. As I had just mentioned, I wanted to refer to another article in our Constitution, and that will be Article 19 of our Constitution. And this one specifically focuses on the responsibility of the state, the responsibility of the family, the responsibility of the society to to protect the child. So in terms of guidance and where I would like to go as a nation, it's clearly captured. And of course, it's not only the Rwandan Constitution, but there are quite a number of other laws. There are quite a number of policies in place that guide us, that have been enacted by the government to ensure that the child is protected from any kind of harm. The list of those policies and laws is quite long. I'll not get into it, but would like to encourage that as we continue in the domain of research, these also be a branch from which we start as we carry on and carry out the different work. In addition to what we have set ourselves as government, we also appreciate that we are not working by ourselves and by our own. We are part and parcel of this world. So in the same spirit, the government of Rwanda has aligned itself to a number of international treaties and laws, again, all in a bid to promote the family, but very importantly, to protect the child. This means that as we continue the journey, not only do we draw elements from what grows from within our society, but also we look left and right, south and north, to see what others have done, and we learn from them. And I'm certain that part of what you do as an academia community in the domain of research reflects that in great magnitude. I've mentioned what is already in place to help us ensure that the family is protected, promoted, and the child, as part of the family, is protected. But I also would like to, for a moment, speak to the fact that the challenges that are being faced by the family, being faced by children, are still quite enormous. And the journey ahead of us is still quite long. So we still recognize that, and we continue to put in efforts to ensure that we work together to continually improve the child development and child well-being at large. These challenges have been mentioned, and they range. They range from those that affect directly the physical, the mental, the cognitive development, the social, all aspects of a child. That said, we also recognize and know and appreciate that families are still being faced by a number of challenges, which in turn lead to the unfortunate hindered development of the children, of some of the children. I'll mention a few here. Some families, due to the different reasons they are leading the life they lead, when you zoom in on the child, you can very quickly say this child is neglected. And once the child is neglected, many things can happen. We can start off from the violence that the Deputy Vice Chancellor mentioned. The violence cuts across ranges. We all know that, and I'll not get into the details. We can get to the component of this child not receiving sufficient care and nurturing, which can result into their delayed development. We can get into the component of parenting, where we unfortunately still have harsh punishments in the name of ensuring that this child is very obedient and all that, but then someone does it the wrong way, not because they don't want to do it the right way, but sometimes because what they believe is that that's what they're supposed to do. That requires a lot of effort for us to be able to get to where we want. And again, the environment is set for us to do this, and it's through partnerships, through the different angles, and today here, the angle of research that will help us achieve. As the government strives to establish the laws, the policies that I just alluded to, that protect the family and children's rights, I would like to once again echo that research institutions are highly, highly recommended to conduct research and invest in child well-being, child development, to further inform the policies that are drawn and the way we implement. I would like to take a moment here and request that we continue to put efforts in the research, be it for what has been started, already what has been implemented. There are a number of interventions we put in effort and are being implemented. But I'll be very genuine with you here that for some of those, you'll say, okay, it's been 2 years or 3 years. What have you achieved? We might tell you what we have achieved up to the level of a facility, but what have we achieved at the level of a household? This is very important, and I would like to call upon the university to help us and work with us on this journey. Interventions that are being implemented, how can we work together to ensure that all of them are actually studied as we implement them? What is it that we are not doing right? What can we change to get better results? What can we change to get better results with less cost? What can we change? I can go on and on and on. And then the second area is for areas that we have not even started yet, that we have not yet ventured in. I know for sure that when researchers get into an area, study it, and come to the policymakers and say, we have actually followed so many children, so many families, we've been doing this for so long, and this is what we've seen. The government that I serve will immediately jump onto it. The only reason they wouldn't is if it doesn't fit in our context. And speaking of context, and before I conclude these remarks, I would like to give you an example, researchers, so that you help us on this journey. I once looked through a questionnaire of a national survey, a survey that we respect so much. It was on questions about children development. And behold, as I did, trying to understand a certain figure, I said, no, I have to look at exactly what they're asking. And when I did that, I realized that one of the tools they were using to measure the level of development of children in Rwanda was using a mirror. A mirror? So the researchers would come with a mirror and show it to a child to see if the child knows how to use it, a little child. You will all agree with me that if the child has never seen a mirror before, they will not know how to use it, right? Does that mean that this child is not developed? No. So as researchers, how do we ensure that as we work with others around the world, as we try to translate what we are learning from elsewhere, when we are going to use it here, we make sure it fits in our context. This is very important. Because at that moment, after understanding that it was the mirror, I said, please put it in the dustbin. I'm just giving you an example. So there could be many others. So here, I took a moment there to emphasize the importance of carrying out this research as we learn from elsewhere, but also that fits in our own context. The other arm will be studying what we can implement here. If a study is so nice and it shows us results, but when it's not practical in our context, we unfortunately will not be able to implement it. So it would be a very good study, but will we use the results and the recommendations from that? If we don't, then again, it would not have been put at, best use. So with that, let me conclude by once again saying that this research symposium is truly a good platform to discuss research conducted on topics that inspire evidence-based practices in child mental health and child development in our country. And I very much take this opportunity to thank the director of the Center of Mental Health, the organizing team that put this together, the partners working with you on this journey, for putting this together, for organizing this symposium so that we'll get to share the outcomes, to influence our policies as we continue to move towards improving the development of our children. On behalf of the Honorable Minister of Gender and Family Promotion, I would like to commend the partnership that exists between the University of Rwanda and the Boston College, and to reiterate that the ministry is very supportive of this continued research in the domain of family functioning, child development, and child mental health. Once again, we thank the university very much, and we thank all of you here present and those joined in online. And I take this opportunity to wish all of you fruitful discussions. Thank you.
Thank you very much, Dr. Anita. Dr. Anita Asimwe, thank you for your remarks. Thank you for reminding us of the importance of partnerships and collaborations in the country's mission to promote family, as well as the child's well-being, as family is the cornerstone for the development of the country. And also thank you for emphasizing on the necessity of research, for research institutions to do more research, to put more effort on researching on child development. Thank you. Without further ado, we're going to start with our first round of presentations. With the title Mental Health and ECD Research, I would like to welcome the moderator for this next session, Ms. Umulisa Rurangwanili, to come and welcome the panelists and the presenters for this session. Thank you.
Good morning, everyone. As we enter into the first section of the day, we are going to look at some of the researches that have been conducted in the area of early childhood development. And without further ado, I would like to welcome the first presenter, who is Professor Leticia Nyirazinyoye, a professor at the University of Rwanda in the School of Public Health, who is going to present a study entitled Perceived Barriers and Facilitators of a Family-Based Early Childhood Development Intervention in Rwanda, Insights from Parents and Community Leaders in Rwanda. Allow me to welcome her as she takes us through the study that was conducted. Stage is yours.
Good morning, everyone. Let me put myself to the other side. Good morning again. Dear Deputy Vice Chancellor of the University of Rwanda, and dear Dr. Anita, our principal of the College of Medicine and Health Sciences, and Dr. Vincent, the director of the Center for Mental Health, and other ladies and gentlemen, our distinguished guests, I would like to take you through one of the studies that was conducted in Rwanda. It was a secondary data analysis of the baseline study that was conducted by Boston College, the University of Rwanda, in collaboration with MIGEPROF, UNICEF, and the Imbuto Foundation. And the study was a baseline for the Sugira Muryango intervention, but the University of Rwanda provided additional funds for myself and other colleagues from the School of Public Health to focus on the qualitative part of it. So it's a qualitative study that was aimed at understanding the barriers and facilitators of ECD interventions as perceived by the beneficiaries of these interventions, by the implementers at the family and village level. Next, please. So before so I would like to give you a definition of ECD interventions. Sometimes we talk about ECDs, but the UNESCO in 2001 defined it as a comprehensive approach, as it was mentioned, to policies and the programs for children to ensure their rights from birth to 8 years of age. Their parents, caregivers, and this comprehensive approach aiming at protecting these children's right to develop their full cognitive, emotional, social, and physical potential. And later on, in 2009, a consultative group kind of highlighted that ECD interventions are meant to help children develop and learn in a healthy and normal way. So in addition to basic needs for health, education, and protection, so also needs for interaction, stimulation, affection, security, and learning should be met to ensure children to develop fully. And as a background for Rwanda, it was already mentioned that our government supports the child development, and it was also mentioned that this is visible and it's very well stated in our policy documents from the Constitution, our poverty reduction policies, And we also have a national ECD policy and strategy that was developed by MIGEPROF in 2011 that state implementation of ECD through center-based and home-based interventions. And this was done in collaboration with the UNICEF, Imbuto Foundation, and other stakeholders. So the study was done from 2013, and the data were collected in 2014. And by then, there were 14 ECD centers operating in the country. And the baseline evaluation team was composed of the Boston College from Harvard University and the Partners in Health and the University of Rwanda. So this qualitative study had 3 specific objectives. One was to identify perceptions of primary care givers and the community stakeholders about barriers and facilitators to ECD interventions at a child level, caregiver level, at family and community, as well as culture and the policy levels. The second objective was to document perceptions of our study participants about activities that are used by Rwandans to foster early child stimulation and learning. And the third objective was also to get some suggestions and recommendations from participants, from parents, from village level, local leaders, and stakeholders to improve and to also inform development of ECD interventions of the Sugira Muryango before it was implemented. As I said, this is a qualitative study, so we used key informant interviews for the sake of the secondary data analysis, but there were also a national survey and also focus group discussions. But these findings I'm going to present are only from 40 key informant interviews with caregivers who are parents leading parents evening talks, and some women who are representatives of the Women National Council at the cell level. And we also recruited local leaders at the village level, the village chiefs, and at the cell level. We also interviewed nursery and the primary school teachers and community health workers as the key stakeholders involved in early childhood development. And these interviews were conducted in 10 districts that were 2 districts from each province of Rwanda. So we had Gasabo and Nyarugenge in Kigali City, Gicumbi and Gakenke in the northern province, Goma and Rwamagana in eastern province, Nyamasheke and Nyabihu in the western, and Nyamagabe and Ruhango in the southern. So these 10 districts were selected purposively in collaboration with the research team, UNICEF, and Imbuto Foundation. So we collect data from between July and October 2014, and our interviewers were trained before data collection. All 40 interviews were conducted in Kinyarwanda, and they were also analyzed in Kinyarwanda by myself. I was doing it in my postdoctoral research, and I had also research assistants. So we analyzed everything in Kinyarwanda, but we had 6 interviews translated into English to allow our partners, naming Professor Teresa Betancourt and other colleagues from Partners in Health who are English speakers, for them to understand our data and also help in the analysis. So we started by identifying the main themes and sub-themes from an open coding. It means that we read the transcripts and then we see the key information that is was mentioned by our participants, And then from the open coding, you have a list of code that we further analyze, and we construct categories, and we do actual coding, meaning we establish relationships between information that is provided by our participants. Then we identified some quotes or quotations from our participants. This is the evidence that what we are representing came from study participants. And in the analysis, we used an ecological framework so that we show facilitators and barriers to ECD interventions at the child, individual level, caregiver level, family, community, and the country level. So these are the 10 districts where our participants were recruited from. And the findings were firstly on perceptions of our community stakeholders about ECD services. And they all knew those services existed, but they were confused or integrated with nutrition community program run by community health workers, but also with the ECD centers that were developed were known by local leaders as part of nursery schools for children aged 4 to 6, preparing them to enter primary schools. And we also asked them about the family. So Rwandans, parents, and our local leaders defined the family as composed by father, mother, and children. But other participants also say even families without children, they are still families. And for others, they said family in our context is parents plus other relatives and other people who live in the house, considered as family members. So when we talked about barriers and facilitators at the child level, our participants highlighted that one of the facilitators for the child is the child himself or his characteristics, including his pathways to learning. And then the availability of caregivers and interactions between children and their caregivers, availability of basic services to the child. Is the child well fed? How is the health status, including mental health? Is the child able to attend schools or ECD centers if they are available? But they also said the access to each individual child to existing interventions or programs, namely poverty reduction programs as the VUP, Girinka, Kitchen Garden, even Imihigo and other homegrown solutions implemented to fight against poverty. But there were also barriers as perceived by our participants. One of them was neglected of the child, especially due to alcoholism, but there were also other barriers, including lack of access to services, including health services, long distances, unsafe environments, leading to lack of attention, family violence, child abuse. And one of our local leaders stated that some of the very young children, they are rushed to school and they have to travel long distances. And this is not good for children, and it might be a barrier for them to access services. At the caregiver level, the facilitators were that children are taken care by their mothers in our communities, but anyone else in the community is also responsible of the well-being of the children. And female neighbors are mostly willing to help caring for children. And the local leaders, community health workers, all the sisters and brothers are also helping parents to take care of children. And Rwandans caregivers also encourage their children to play with other children. So go stay with the other children, play with the other children. These are the facilitators, and in terms of barriers, fathers are less willing to be involved in caring for very young children, and some of the caregivers, they lack education, some of them are busy, not available, and also they are not used to play with children. In the family, including parents and other people in the household, there were facilitators, including health and wealth of the people in the house, access to information, education, and other community services. Location in urban area was felt as an advantage to child development, and the parents were keen to initiate and talk with their children and provide safe environment. But barriers included poverty, large families, lack of support from communities, poor understanding and ignorance from caregivers and other people in the house, and lack of knowledge about age-appropriate milestones, and lack of information about available services. And at the community level, facilitators identified were these community opportunities as parents participating in cooperatives, access to small loans, social and economic development programs, community mobilization, and other facilitators were availability of child program, especially those targeting the poorest families, support from the government, local leaders, and other stakeholders. But in terms of barriers, lack of infrastructure, material, and incentives for teacher in those ECD centers and the nursery schools were mentioned as a barrier at the community level. Other barriers were the lack of space for children and parents meeting. Sometimes houses are very small, and also gender norms in regards to fathers' involvement in child care. As a conclusion, the current study expanded existing knowledge about accessing local leaders and parents, teachers, to document these barriers and facilitators, because these community stakeholders, their perceptions is key to development of ECD services that take into consideration our context and also help with suggestions on how to reduce all these factors that are hindering early childhood development interventions. Thank you very much.
Can you please help me thank Professor Letitia for her good presentation? While she's still here, I would like to ask people from the audience if there's anyone who has one question to ask it or any comment. Okay. All right.
Thank you very much, Professor Letitia and the team. Mine is not actually going to be a question, or let me say it's a comment. I was even discussing with Dr. Anita that this is a very good study. And if you look at the findings, you will see that most of what you came up with this study is something which we were aware of this, but we wanted evidence through research. But this study was conducted a long time ago, 2014, and we are in 2021. It's just a comment or a question. Did we, I guess it was published, but did we take the findings to another step? Because we need all the findings to be used, to be translated into action once any research has been completed. But I'm not commenting about this sole research because I know it's a problem for so many papers, good papers we have at University of Rwanda, but I'm very much interested in this one. I just want to know whether it has been taken to another step, whether findings were used. If not, that is the reason why this symposium is taking place, involving other stakeholders from other universities, from the ministry, and that is why I'm sitting here as one of the university managers. We would like to know whether this has been taken to another step. Otherwise, we can reflect on this even at the end of this symposium. Thank you.
Thank you, Deputy Vice Chancellor. Yeah, your comment is relevant. So as you said, this study is quite old, but in 2015 it was presented in different meetings. But we also published a full report of the whole baseline study, and it's available online. I have shared with the School of Public Health and on the website of the school. And also we are kind of finalizing a publication as to close out the postdoc program. But we also, this information was discussed and used to design the Sugira Muryango intervention, and also to put on board the community leaders and stakeholders that we interviewed, because there were other further interviews with district stakeholders, even at the national level. And this helped to design the interventions, the materials, even the data collection questionnaires that were used by Sugira Muryango program and intervention. I think it will come later in other studies that will be presented. But it was like the initial study that was conducted at the beginning of this intervention. Thank you.
Thank you so much. For the sake of time, yeah, it will be good if we save some of the questions. We'll have a lot of opportunities to ask them, and more is coming. Talking of that, we're going to have another presentation by Sugira Muryango with the title of Expanding Early Childhood Development Through Home Visiting. And this will be by Ursula Kajani from Boston College. Please help me welcome her.
Thank you so much for that introduction. First of all, I would like to thank several folks here in the room, the DVC, the Director General, the Principal, and Dr. Vincent, of course. It's my honor here to be sharing a little bit about what we're doing with the Sugira Muryango program now. And so I hope to also address the question that was asked previously. Great, so the Sugira Muryango program is currently in its expansion phase. The program is an evidence-based intervention that is designed to improve responsive parenting, improve early child development, and reduce violence in the home. So it targets the most vulnerable households in Rwanda in Ubudehe 1. And it has been shown to improve key child development outcomes, including early stimulation, nutrition, and reducing violence exposure in the family. So here you can see on the slide there's a QR code. If you have your phones out and would like to know more about our work, you can scan the QR codes to access our publication. So a little bit about the program. So Sugira Muryango is a 12-module curriculum that is delivered in the home with the family. So the module content includes standard content on early stimulation, nutrition, hygiene, but it also addresses family conflict through conflict resolution and stress management in order to address risk of family violence. In addition to this, we also support the navigation of formal and informal resources. So our program has gone through extensive stakeholder mapping in the areas that we're currently active in order to create a database of services that are accessible by our families. So we also recognize this program as flexible for all family types. So whether it is a single-headed household, whether it is a dual-headed household, or even a multi-generational household, the curriculum is flexible in order to provide the curriculum in a way that is customized to the family and the dynamics in the family. So it is standard content, however, it's customizable, and in our trainings we also discuss how to customize to provide the information that is most relevant, most important for the family in order for them to meet the needs. We also have a strong emphasis in father engagement. This is emphasized through our visuals and messaging, as well as through flexible scheduling. And so what we do is our interventionists go into the household and they discuss with the family when the modules and when the visits will take place. And so by doing this, we aim to engage fathers who are often not in the household until later in the evening, on the weekends, things like that. So we're able to actually engage fathers into the module sessions. So we deliver the information and have the discussions as a full household. We also incorporate 15-minute play sessions into each one of our visits. These are with homemade toys. So we go through a process of discussing and co-learning about what homemade toys can be made in the household based off of the materials that are available in the surrounding environment. So we want to emphasize that creating toys and playing with toys and engaging in early stimulation does not have to be with pre-made toys that you purchase from the local supermarket, but it can actually be designed and created in a very effective way from the resources that are available around the community. And we also see our program as complementary to ECD centers, community sensitization, and home-based childcare initiatives. And so when we're in the household, we're also simultaneously advocating for these families to get connected to other ECD services that are in their community and available to their children. So here you can see a list of our modules. So you can see the standard content around hygiene, nutrition, health, and then conflict resolution, sharing of responsibilities. But I also want to emphasize the first module. The first module is the family narrative. So this is where our interventionists go into the household and they have a discussion about the family history, the family dynamics, and really try to understand what is happening in that household. We believe that every household is unique. They come with their own set of challenges, but they also come with their own set of strengths, right? And so our program is strengths-based. We want to see what strengths already exist in the family, how have they dealt with challenges in the past, and how can they leverage those strengths in order to deal with challenges in the future. Great, so as mentioned previously, the program has gone through several cycles, as you can see here. We've had 2 pilot studies, and the latest is a cluster randomized trial consisting of 1,049 households. So we initially started with bachelor's level trained interventionists and have now, in our current expansion program, we are starting to engage the Inshuti Zumuriyangos, so they're community-based workforce housed under NCDA. But here you can see a few of the outcomes from our cluster randomized trial. These include things like more stimulation and increase of play activities in the house, an increase in dietary diversity and care seeking, but also a decreased exposure to violent child discipline and an increase in exposure to nonviolent discipline. We also see a reduced victimization to intimate partner violence among mothers and a decrease in mothers and fathers meeting clinical criteria for depression and anxiety. So these are, again, just a few of the outcomes from the CRT. However, if you'd like to see more of the detailed outcomes, I encourage you all to check out our recent publication. So where are we now? How has all of this information, how has all of this research culminated? So currently, as I mentioned, we're in the expansion stage of the program. So the cluster randomized trial involved 1,049 families. We're now saturating completely through the districts of Nyanza, Rubavu, and Ngoma. And we're utilizing the Nshuti Zimmeryango workforce that is housed under NCDA as the interventionist for the program. In addition to that, the expansion program is also testing an implementation strategy. So this implementation strategy is called the Promoting Lasting Anthropometric Change in Young Children's Development, or PLAY, collaborative. Government officials, our local leaders, our community health workers. We want to increase the sustainability of our program, and we want to improve the quality while the intervention is actually happening, not after, right? So we want to catch these challenges, we want to try solutions, and we want to be able to use the PDSA or the Plan, Do, Study, Act cycle during the intervention for quality improvement, rather than waiting till the end of the intervention in order to assess what were the challenges. So along with this, we also have cross-site learning, right? We want to learn between all of the different sites that are going on with this program, right? As I mentioned, we're saturated in the district, and we have play collaboratives at different levels. In order to make sure that we're not missing cross-site learning opportunities, we also have a cross-site seed team that will be communicating throughout the entire intervention, sharing knowledge. And lastly, we're also looking at the use of gamification strategies to engage, motivate, and increase the accountability of the Play Collaborative. So I hope that was a brief introduction to the work being done currently based off of the research that came before. And I want to give a special thank you to our partners here at the University of Rwanda, but also NCDA, as well as our generous funders, without whom this project could not have been possible.
Thank you for the great presentation, Ursula. It's going to go as it went in the last presentation. In case a person has a comment, reflection to make, or question, this is the time. I think people are still reflecting and digesting what has been said, and yeah, there will be other opportunities for great discussions. Without further ado, thank you. Allow me to thank her again as she joined her seat. We're going to welcome the last presenter in the section of research in ECD, or childhood development. And this is Dr. Vianney Nyirimana, a psychiatrist at the hospital of at the university at CHUB, and he'll be presenting his study with the title of Prevalence of Childhood Adversities Among Inpatients with Mental Disorders at Caraes Ndera Neuropsychiatric Hospital in Rwanda. Please help me welcome him as he come and give his presentation.
Thank you very much. My name is Dr. Vianney Nyirimana. I am the head of department of mental health here at the CHUB. I would like to thank you all of us who have attended this audience. So this is the research that I have carried out when I was a resident in order to obtain. Yes. In order to obtain a master's degree in medicine in psychiatry. The title of the prevalence of childhood adversity in a patient with mental disorder at the Neuropsychiatric Hospital in Rwanda. Next. The objective is to help how to mitigate the consequence of adverse childhood experiences in Rwanda. Next. The background was the socio-economic challenge that the world is facing today. So how to mitigate those socio-economic challenge that the world is facing, including Rwanda? So the world need to keep children's physical and mental wellness in order to provide the well-educated and healthy adult population with enough skills to overcome significant burdens related to socio-economic challenge. So this responded to this responsive caregiving has long-lasting effect on the child, physical and mental wellness, fewer behavior problem, and less involvement in social services and criminal justice system in adulthood. This is such a study that have been done in other area of the world. Continue. Children with history of insecure attachment and lack of love and trust are more likely to vent their childhood rage and pain to the community during adulthood. This is the key of this my presentation. If you forgot everything but you keep this, it may be helpful. Why? Because we have children in the society. If the child has insecure attachment in early development and lack of love and trust, soon we are waiting what? We are waiting the consequence. The consequence, it is they will vent their childhood rage and pain to us as adults during adulthood. Reason why you have to tackle this problem during early development. Indeed, previous studies have established a strong link between adverse childhood experiences and the poor adult health outcome. Continue. So those are adverse childhood experiences are those potentially traumatic experiences during childhood. So what are these? Child abuse and neglect and growing up in dysfunctional household, which is characterized by domestic violence, mental illness, incarceration of the household member, parental divorce, separation, and household drug and alcohol abuse. Those adverse childhood experiences give rise to toxic stress response, which is the origin of childhood trauma. Next. This childhood trauma may disrupt neurodevelopment, and this disrupted neurodevelopment results in a cognitive, emotional, and social dysfunction to the individual. Individual with this dysfunction may be at risk of increased risk of health harming behavior, disease, and disability, and premature death. Continue. This is the research that has done in the CDC, which was explaining the relationship between adverse childhood experiences and health outcome. Continue. So the National Scientific Council of Only Developing a Child has established 3 categories of stress response in young children, meaning positive, tolerable, and toxic stress response. What is positive stress response? It means there is exposure to mild to moderate activation of stress response system with the availability of caring and responsive adult who help the child to observe and learn, practice healthily in order to facilitate the child to return the stress response system back to baseline status. Continue. What is tolerable stress? It means that it is exposure of child next. Tolerable stress, it means it is exposure of the child to high in magnitude of it is activation of stress response system. What make tolerable stress different from toxic stress? It is a buffering, protected adult relationship that facilitates reduction of physiological stress response, promoting a return to baseline status. Toxic stress response, it means the child has been exposed to high in magnitude of stressful event with the absence of the caregiver. Donc, there is an absence of buffering factors. Reason why it is called toxic stress. Toxic stress occurs during child development because in this situation, the brain and the body of the child are still developing. Next. So what is the statement of the problem? Childhood is the foundation of adult health outcome. Reason why the UNICEF is striving to increase global investment in early child development. So despite this insight, ACs remain an important and addressed public health issue that our community are facing today. Because few cases of ACs perceived from social media represent only a small part of the problem, as many cases remain hidden far from our side. Next. So it means that lack of this information of ACs contribute to the endemism of child exposure to ACs. And this knowledge gap in the clinical service usually leads to less appropriate treatment plan, and we lose the opportunity to treat childhood trauma known to be the origin of poor health later in life. Next. What was the research question? What is the prevalence of childhood deficiency among patients with mental disorder admitted in the post-crisis ward at Indela? Those are my objectives to document patient socioeconomic variables to define the prevalence of ACs among patients with suffering from mental disorders and to assess the correlation between ACs, AC score, and patient socioeconomic variables. Next. Relevance of the study. This study will contribute to improvement of mental health care delivery through addressing this problem from the grassroots. Given that no AC study have been carried out in Rwanda, our finding will clarify the AC burden in a patient with mental disorder. In the community, our result will motivate the establishment of best intervention for AC prevention. Using AC screening tool in clinical practice will facilitate to make appropriate treatment plan. Next. That is the literature review that clarifying the burden of the problem in the world. So the survivor of childhood trauma may have a multiple overlapping psychiatric disorder and several health conditions from trauma-related disorders according to previous research study. Next. Continue. What are the results of this? There's a finding. We recruited 159 patients and 122 have participated. So the main finding is that 67.22 had at the most primary school grade. It means that they didn't go beyond primary school. This is the big challenge, education. Second, next. A second finding is that adverse childhood experiences are common in patients with mental disorder because all of them, at least all of them, have been exposed to at least one adverse childhood experiences. Next. Those are findings. Continue. That was what I was saying. In my population, according to the level of education, 61.5 didn't go beyond primary school. This is a big challenge in patient mental disorders. Don't go? Continue. Continue. Again, to the level of the employment. In the employment, 42.6 of those patients were not employed during 12 months, previous 12 months. This is a big challenge to the level of the workforce. Continue. 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 This was a discussion that I have a challenge of time ahead. I want to read the recommendation. Recommendation, yes. Continue. Yes. Discussion. There is a high prevalence of ACEs in patients with mental disorder and the paucity of data on ACEs in Rwanda. Early recognition of ACEs with appropriate intervention can mitigate the negative effect on child development and can lead to better health outcome. Next. So there is also intergenerational transmission of ACEs. The child who has been exposed to ACEs, there is a high risk that the offspring will be exposed also to ACEs. It was we see during our clinical activities. The recommendation you have to use, because it is a public health crisis, we have to find a public health solution. It means you have to use primary, secondary, and tertiary preventive measures. What is the result of the objective of primary prevention? It means it is to prevent harmful exposure of children to ACEs. What can you do? Raising public awareness of ACEs and identification and addressing family problem, family promotion, and training on positive parenting and support further AC research study in the purpose to improve child protection in human society. Next. It is requesting all healthcare providers to prevent the transmission of toxic stress response during pregnancy by engaging both wife and husband, including other important individuals such as employers, friends, and family members. Next. Secondary prevention, it means early detection of those children who has harmfully exposed to ACEs and provide appropriate intervention on time to prevent development ACEs associated and AC-associated health condition. It means it is urgent to make AC screening early in childhood and provide an appropriate treatment to the victim in the purpose to tackle upstreaming problem before the complication and overall long-term pernicious consequences. Next, it is tertiary prevention. It means to provide appropriate treatment to individuals with ACEs associated health condition. It is requiring the introduction of trauma-informed care. Another key term that you have to maintain in your brain. It means trauma-informed care in our health system, and to train not only clinicians, but also you who are not clinician on ACEs and trauma-informed approach in order to help people not only to recognize the origin of the diseases, but also to improve therapeutic outcome. Thank you very much for your attention.
Allow me to thank him again for this insightful presentation on a crucial topic. As we move forward, he will stay with us. So in case you have questions, please keep them, because we're going to have a panel with him and 2 other people who are joining us on the panel. And the panel will be made by Caroline de Save, an ECCD specialist at Save the Children Rwanda. Help me welcome her as we dive into an interesting discussion. We're also going to have Dr. Vianney Nyirimana, who was presenting as well a few minutes ago, the head of Department of Mental Health at CHUB. And last but not least, Karibgende Françoise, a clinical psychologist at SOS. Since the start, we've been looking at different studies that have been conducted around ECD, the different programs that has been implemented around the country when it comes to taking care of the child and enhancing their well-being. That being said, I would love us to dive into this panel's discussion theme, which is advancing early childhood mental health support program, both in rural and urban areas. With that being said, I would love to ask Caroline to give us insight on what are the current programs of ECD that are here in Rwanda.
Thank you so much. So there are different types of programs, ECD programs in Rwanda. The most common ones that people know about are center-based programs. For example, those targeting children 4 to 6 years who are in the preschool age period. So that may include the 1-year pre-primary that is attached to a public primary school. It may include a community-based ECCD center that is taking children from 3 to 5 or 3 to 6. It may also include private ECCD programs that are also taking children from 3 to 6 years. But we are seeing more and more programs also targeting children from birth, which is really exciting. And the birth to 3 age range is mostly served by parenting education programs, where we train parents on how to provide nurturing care, including responsive caregiving that Dr. Vianney has been talking about. It also includes home visiting programs like Sugira Mudyango has presented about. So in this case, community health workers or Inshuti z'Umuryango will visit a family and have structured discussions about how to promote early childhood development. And also during the parenting sessions, again, it's having structured discussions, role modeling, demonstration to parents in the community on how they can support their children's well-being and development. We also have what we call the home-based ECD, which is where parents will come together and they will take turns looking after their children being left in someone's home. So that is a kind of home-based daycare service program, different from home visiting and different from parenting education. But also we see parenting education for families of children in the preschool age period and also in the early primary grades, because we've seen that the ECD period spans from prenatal to 8 years. So we have to be thinking about supporting children in formal settings like schools, ECCD centers, as well as in the community and in the home. So in Rwanda currently we have those programs that target those three important areas: the home, the school, and the community. Yeah, thank you.
Thank you. Thank you for giving us an overview of the current programs that are available in Rwanda. But there is an abbreviated term that I would love you to share with us what it means in full words, which is the ECCD, for everyone to be on track.
Okay, thank you. So in Rwanda we use ECD, but actually it means the same. ECCD is early childhood care and development. So early childhood care and development. And then some people will also say early childhood development. So some people will remove the care component because they are assuming that they will probably not be attending to the issue of the parents and the relationship between the parents and the children. But in Rwanda, we talk about the ECD, the early childhood care and the early childhood development, to include all components. The care that is given at home by the parents, and here parents, we are not talking about only biological parents. In the earlier presentation we had in Africa, it's not only biological parents who provide care, but we're also talking about other areas of development, including learning, which is provided at the formal setting. But also we remember learning starts from birth. So the foundations for learning will be developing even before a child is in school. So we are also seeing that the home is an opportunity for promoting learning. The other word that I can probably break down, because it's going to come from the discussion, is nurturing care. So when we talk about nurturing care, we are talking about holistic services for children, including early learning from birth, responsive caregiving, which is about the connection between the child and the parent or the caregiver, and it includes the caregiver being attuned or attentive to the needs of the child, as well as to the cues, the messages from the child, and then responding on time and appropriately. And then we also have safety and security, which Dr. Vianney has mentioned a little bit about, including protecting children from violence, protecting children from neglect, protecting children from common accidents, as well as health and nutrition, which I think most of the people here understand, because we've been talking about health and nutrition a lot, but not enough about responsive caregiving, not enough about early learning from birth, and not enough about safety and security. Yeah, thank you.
Thank you so much for making those clarification and explaining how also ECD highly stresses on health and nutrition. And now going specifically on the health axis, I would love to ask to Dr. Vianney, what do you think should be, where should mental health fit in all that, as the child's development is being cared for or focused on? What should be the place of mental health, as we've seen that there are some disorders that develop at childhood or start during childhood? What should be the place of mental health in the ECD?
Thank you very much for your good question. What can be done? So based on of other area of the world, what they are doing, there is what we call behavior risk factor surveillance system. This program of behavior risk factor surveillance system is a good program that we can implement here in Rwanda, because those challenging behavior that we're facing actually could be detected during early period, and then we can give immediately early intervention so that we can treat. Because when we provide intervention on time, there is a good result. But if you are late to intervene, the consequences are dramatically huge. So for me, we have to implement it early so that we can have a strong behavior risk factor surveillance system. Again, in my presentation, during my recommendation, you see that early detection, secondary prevention, early detection and early intervention is very useful to mitigate those pernicious consequences. But you can't use only one approach, only one intervention. You have to use primary, secondary, and tertiary prevention. So for me, in summary, early detection and early intervention are very useful. Yes.
Thank you so much. As you heard him say, prevention is better than cure, and the earlier, most especially, these childhood mental health disorders are detected, the earlier the intervention will be, and this would help the child continue to develop without any problem. And this leads me to Françoise and ask her, as a person who has been working at SOS and with children, what have you seen that has been working in the Rwandan context in terms of the mental health care for children, and if this could be something that could be implemented in the already existing programs of ECD that are already available and already operating out here? Thank you.
Thank you, moderator, for your good question. As SOS children, we work with children since long time. We have children in the village, and now they are in the process of reintegration into their families. So now we have children in the community. In SOS, we work with children through different psychotherapies, including narrative therapy, where we help children to talk about their stories through games, songs, and drawings. And we have other therapy called psychodrama with children, where we use games to help them. And we help children through also group sessions and individual sessions. And as ECDs, now we have MOU with the Minister of Gender and Family Promotion. We are starting to talk with the ECDs, and we recommend to implement mental health approach in ECDs, where those children between 2 and 7 years, they are children who are in stage of pre-operation stage. Children need symbols, where we help them through games, toys, and we help caregivers and parents through group sessions also to know or to identify some behavior disorders among children, including attention deficit and hyperactivity, anxiety disorders, conduct disorders, and we help parents or caregivers to identify, to know how a child behave and how to react. We help also caregivers to know existing communities' mental health systems, including health centers. Now, each health center in Rwanda has a mental health officer or clinical psychologist, and we help parents to know how they can go at health centers if a child behave abnormally. Yeah, and we help also, we train teachers to identify also psychological disorders and also to help children. And also we advise ECDs to train ECDs teachers to help those children to identify and to help them through games, drawings, songs. Children like songs, and through those games, different games, we identify how the child behave. The child can develop isolation between others, and now if we use those techniques, and we can realize that the child has a strange or a behavior disorders. As also SOS, we help caregivers to know how they develop their attachment with children, a strong attachment, and to know how they behave regards children behaviors. And now we realize that it works when you pay attention to a child and you give them those therapies or those sessions. And also we work closely with local existing mental health systems. We train mental health officers at health centers and hospitals. We work also closely with University of Rwanda, where we conduct different research at SOS to see how those approaches works. Recently, for me, for example, I conducted the research how to see the role of narrative therapy in behavior disorders healing process among abandoned children in Rwanda. I realized that to conduct those research, to prepare children and to help them through a long journey therapy, and now they are doing well. And I recommend ECDs to implement mental health system. Thank you.
Thank you so much for sharing with us on the importance of mental health in the development of a child as they go into other stages of development. That being said, we talked about the programs broadly, but I'm curious to know, what is the current status now that we have understood the programs that are available and also the place of mental health and its importance in the ECD? What is the current status for ECD programs in both rural and urban areas? Do children in these both settings have the same learning opportunities? To you, Caroline.
Thank you. Before I answer the question on the learning opportunities, I wanted to backtrack a little bit to build on what my colleagues have said about the mental health, the adverse childhood experiences, or the SCEs, as Doctor has told us, and what we need to be doing even before birth. So we know that development or child development happens as a result of the interaction between the child and their environment. And that environment is moderated by the adults, the caregivers. It can be the parents, the other primary caregivers in the home, or even the caregivers at the formal institutions, ECCD center. So what we need to be thinking about is how to reduce the number of adverse childhood experiences and also improve or increase protective factors. Because the protective factors and the SCAs are interplaying in the environment of the child, and it's affecting their development, including development of foundations for good mental health. So If the child has more adverse factors than protective factors, that is when they will end up in doctor's clinic as a mental health disorder case, or they will have other consequences, including poor physical health, poor cognitive outcomes, etc., etc. So these adverse factors, like Dr. said, include, for example, growing up in a household where the parent has a mental health disorder, the parent is alcoholic, even poverty is an adverse factor, poor nutrition, but there are some adverse factors which are beyond the control of people. For example, Nyiragongo erupted, there was an earthquake, there was disruption in the child's home environment. So what needs to happen is to increase the protective factors. The protective factors include love and attention from the parent. The protective factors include having play opportunities, because the play opportunities will help the child to release the big emotions that are coming up because of the disruption in their environment. It also includes improved ability of the parent to respond to what's happening with their child, to notice signs of stress in their children. But some parents in Rwanda don't even know that children get stressed. As young as 1 year old, children get stressed and they can show signs of stress. But parents don't know how to read those signs. Just after the COVID lockdowns in Rwanda, we did a research where we wanted to understand how COVID lockdown has affected the home environment and also the caregiving practices and attitudes. And what the parents said, 55%, and this was a national study, not representative, but we interviewed parents from all over the country. 55% of them said they were feeling more anxious and more stressed than before COVID, and 25% said they were noticing signs of stress in their children. So signs of stress include like extreme crying, refusing to eat, wetting the bed if they never used to wet it before, sleepwalking, and other weird behaviors that are not common for the child. Only 25% said they are noticing. It doesn't mean that only 25% of children were stressed. It's just who noticed and who responded appropriately. So that is where the parenting education programs come in that we give to parents, because it includes training or coaching parents to notice the cues, the signs from the child, and also responding appropriately. So that is something very important. And also it links to what colleagues are saying about tracking these AC factors in the home. Because we can be able to ask some questions to understand which homes have more factors and which have less. And if we find the home has more of these adverse factors and less protective factors, then it's time to intervene. Maybe a home visit, maybe counseling for the whole family, maybe something we can do to reduce the ACs and increase the protective factors. Going to
on the
learning.
As we stick on that, because I think that is really crucial information you shared on the protective and risk factors. Allow me to retwist the question and ask, now how can you use these facilities to enhance the protective factors? How can you use the facilities that are already available, that are offering learning opportunities to children to enhance the protective factors for children as we join in the parents in that journey?
Yeah, thank you. So the first thing is to increase the knowledge of everybody in the population, because currently the knowledge and understanding of mental well-being, mental health, and how that links to child development, how that links to well-being of the family, it is low. People think that mental health is earthquake. People think mental health is like somebody who is having an extreme mental health problem that they are walking on the street, right? But mental health is beyond that. All of us need good mental health. It is not only the person on the street because that person is on the street because they displayed some symptoms before, then the issue graduated until they can no longer cope. So we need to raise the understanding that, first of all, it's okay to talk about mental health in our homes. It's okay to talk about I'm not feeling fine. I need some support from you, my sister, my husband, my wife. My child also needs support. Normalizing the conversation. So one of the things we did at Save the Children during COVID and even earlier this year was to run radio programs throughout the country where we were talking about the regular things about promoting early child development, responsive caregiving, early learning, but we also layered with mental health messages, how to detect stress in your body. For example, you may feel some tension in your back, don't ignore it. You may have some headaches, don't ignore it. We were also giving advice to the listeners, reach out to a health worker. Don't fear to go to the hospital. It is okay to feel stressed in the midst of a pandemic. And also we're talking about the fact that when you're stressed, when you're anxious, you can't respond to your child's needs. So it's very important that you respond to your needs as a parent, as a caregiver, before you respond to the child. So anyway, the long story short, messaging, social behavior change approaches to normalize the conversation, and also to let people know what are the signs, what are some simple things you can do, breathing exercises, praying, meditating, because we can reduce the cases that go to the clinic. There are some cases that need to go to the clinic, but there are some cases that, if you address it early, you don't even need to go to the clinic. Yeah, thank you.
Thank you so much. And on that, you're describing more like the adult perspective. But now I'm wondering, Dr. Vianney, as we know, children respond and process emotional experience and traumatic events in ways that are different from those of adults. And sometimes it's hard for them to speak up and express where the wrong is. What can be done, most especially in early detection-wise? Practical-wise, what could be done to help children, to help detect cases before they burst or before they graduate to something even worse that it would be hard to manage, and that might fit our context, as that is something that has been said from the beginning, that also in terms of solution, this has to be things that are related or fit in this context.
Thank you very much. Children respond to stress differently. As you are adult, respond to stress differently. Why? Stress to children can be in three manners: positive, tolerable, and toxic one. So if the child is exposed to stress which is high in magnitude, in the presence of buffering factors such as responsive caregiving. What is responsive caregiving? It is safe, stable, nurturing relationship with environment. Does this child, even if he has been exposed to highly in magnitude of stressful life event, the adult patient, an adult person who is there to respond to this child need, will constitute a buffering factor that will help the child to calm down. So you are asking, we are screening what is the sign and symptom of the child who has been exposed to childhood adversity. So the child who has been exposed to adversity, we will see the symptom in four manners: cognitive symptom, emotional symptom, behavioral symptom, even physical symptom. So if we start with the cognitive symptom, the child normally, if the parent come back home, he used to go and to see his mother with joy. If you see your child doesn't respond to your presence, this is the sign of childhood trauma. You have to question why the child is used to come smiling to me, and now he's not coming now. So this is cognitive. If the child is going to school, and he used to perform in the classroom, and he started to fail. You have to question, what is happening to my child? Too emotional. How he expresses emotional. Temper tantrum. Tantrum. If the child is expressing his emotional in an unusual manner. So, in our culture, we take a stick and we beat. But it is a bad culture. You have to question why this child is a temper tantrum. Because it is a symptom which is emotional. You have to intervene early to see why the child is responding like this. Behavior, aggressiveness to others, and not comply to internal regulation of the home. Those are the behavior that such children can manifest. Normally, as I said, if the child doesn't comply to internal regulation of the home, our parents take a stick and punish. This is our culture. But you have to change. You have to change because you have to question why this child is repeating the same fault. Why? But our parents will say, yes, there's a symptom. Have to take seriously, and you provide early intervention. Other fourth component of manifestation of toxic stress in children, it is somatic symptom. The parent, the child is complaining headache, picastragia, and insomnia, and so on. Those pathology that those children are developing, and you go to seek the pediatrician. For me, I am working in a good hospital, in a general hospital. This knowledge I have transmitted to our pediatrician, telling that if the patient, the child is expressing epigastralgia, headache, crying, and so on, call me, please. I can help this child. Maybe he's expressing childhood trauma. Because the child, based on his level of development, he cannot say that somebody is mistreating him, but he is expressing by his body. The body of children speak more than their tongue. Reason why they refer those children to me, and I give my ears, I listen what's happening to them, and most of the time the parents are there saying that my child has a severe pathology that needs CT scan, MRI, and so on. But I see the child is expressing childhood trauma. So for me, I have started using trauma-informed care in my clinical practice, and I have seen that it is wonderful, and it is working in saving life of those children, even the adult. So those four components, the cognitive, emotional, behavior, and the somatic component of expression of childhood trauma are those symptoms that you can see to our children. Thank you very much.
Thank you so much for sharing those four important components, but that people should pay attention to each and every single day, regardless of whether your child is being offered a safe environment or not. That being said, sounds like the conversation has been one way, and I was wondering, I would like to invite the audience to also come into this discussion and share their insight as well, questions or comments on this specific matter of childhood mental health and how this can be incorporated into the ECD program.
Thank you very much for the opportunity to say something, for the invitation, Vincent. I really want to appreciate the speakers, all the discussions here, and sorry, Vincent is. I wanted to appreciate the same time. The Center for Mental Health, the Boston College, Sugira, and all the partners. SOS, I know it's part of the programs we are doing. Always we are together. Much appreciations. Now we have Save the Children. I don't know if you have a memorandum of understanding with. So I would really appreciate to have one. Say I should be. I know you're part of us and we are part of you. And Doctor, thank you very much. Last but not least, thank you very much. I think we need to come to you and really start working with you. Not only the Center for Mental Health, but also other programs we have. I think all what you are discussing here from the beginning, it's going through synergy. How do we come together? How do we come together from the community to the education, to the research we are doing in education, to the community outreach we are doing in education, to therapy, to care. So how do we bring all this together? I really like what Caroline said, holistic way of doing things, holistic care, between prevention care and therapy, but the holistic. How do you see the child in the biopsychosocial model? The physical, the psycho, the social, and then the environment. I think environment is cross-cutting. So, and it's really interesting. I think all what we're discussing here are bringing all this together. So, and for the society, so there's a child, family, and then society. Society is really big. So I was trying to understand and try to define what we have in the society. And I think we keep on bringing the community leaders, but I don't hear religious. I mean, you know, when a child is sick, then you go to a pastor and say, okay, it's going to be fine, without even knowing what is the sickness. Now the traditional healers, they're also there. No, my child is not, so not a normal sickness. Maybe I should go to the traditional, because they are still there, and there are many people still believing in them. So all this, the school is a really very, very important sector for community or for society. And all this, they have to be part of the synergy I'm talking about. Now, you are really doing, everyone here, each organization is doing really wonderful work. But if we don't work together from prevention to care and to community promotion, and then we are not going to achieve the big goal of having a child who is really healthy, because that's the definition of health. It's not only being physically healthy, but it's also the whole society, the cycle, and then we talk about the well-being of that child. So again and again, thank you. The University of Rwanda is always ready for partnership. And we are doing all this. We are teaching, we do research, and we do a lot of community outreach. And Vincent, with the SOS, with the Sugira, they are doing together the community outreach and research. And the research, what I'm hearing here, the research, the community outreach can even inform what we're teaching. That's what I'm saying. We are now going to doctor and say, yes, here we are. How can we, all what Sugira presented and all of you, and how can we in SOS, we always have always open meetings when we have SOS. We even have people coming from outside, doctor. I mean, training people from outside. It was what we did with the Sugira, with the SOS, the narrative therapy. So all this, Vincent, I think we need to now see in our curriculum, because it is becoming really important. The child mental health is becoming very important. Okay? So we are seeing the child, but when we look at the adolescent, doctor will tell more about this. It's from the child that we have an adolescent who is fit. And then from adolescent, the adult who is fit. So we need to think twice and see not only our programs or our curriculum, but also the primary, secondary, as it's university. But it starts from primary, then secondary, then university. So I'm talking about many things, but I think it's about synergy, it's about working together, it's about to wake up, and we have doctor organization, which is there. How do we support? Because there is the key of the community. But we need to feed that. We need to bring a lot of information there. We need to bring change. We need to transform. We need actions. So those are my interventions. Again, thank you very much.
Thank you so much for emphasizing on how also these programs can nurture into the university or curriculums that are being taught. For the sake of time, we're going to welcome 2 more questions and proceed with the program. Thank you.
Thank you so much. I have a question for Dr. Vianney, and thank you so much for the panel. It's quite good to listen to, but I will go direct to the question. Dr. Vianney, as I looked at your data, I was wondering if you're considering to go a step further and do the same exercise among people of the similar age and, if possible, similar background, but who are not your clients in the mental health clinic. I'm thinking of this because of most probably, I'm trying to reach out to what Caroline said. It's one thing for the environment to be having the adverse effects for the child. It's another thing for that environment to be having protective effects. So maybe people who have similar exposure, one has protection, another one doesn't, and so we end up with what we have. So I'm just wondering if it's a possibility for you to look further than the group you have at your clinic, who might be, similar age, similar background, and see, how is their education, all the other factors that you looked at, if possible. Principal, if I may, to your point, I think one thing that can help us strongly improve early childhood development and child development at large, because early predisposes to adolescenthood and later on, is, if at least as a university, if we figure out how to include, for now I would say early childhood development, within the courses that you give. It could be a one-credit course, but it's very important that the people we have access to, at least through education systems, we prepare them. We tell them what it means to be a parent before they become parents. Many people are becoming parents because that's what society expects them to be. One of the presenters, I think it's Dr. Letizia, when she was defining the family, what the community said the family was. And so we are growing up in a society, not just in Rwanda, in society where people think a family has to have children in it. And automatically you have, when you reach a certain age as a man or a woman, there is a sense of incompleteness if their family is not there, and if the family is there and without children. But what we don't know is what awaits us as parents. So I think we need to have a further discussion with the university. Can we tell the students when they're still a little young what it means to be a parent? It's not just for fashion. We have to take care of these children if we are going to protect them from situations that the panel is talking about. This is a lovely discussion, and I'm glad that I stayed longer. Thank you.
Thank you so much. One more question there at the back. At the okay. We'll have one question here and the last one there at the back.
Okay, thank you. I really appreciate the discussion, but I have the concern on inclusion of children with disability in ECD program. I would like to know the strategy put in place for helping them or to remove the barriers which can stop the children to attend the ECD program, especially the barriers of communication, the barriers of accessibility. Yeah, thank you.
Thank you so much. We keeping that question, and there was one question there at the back. Yes.
I want to thank all presenters for the good presentations. I have a question regarding policy and practices. I was wondering if there is any policy on ECD, and if yes, from the practice perspective, is it integrated in community health workers and primary health care system, and second, in education system? Because if we want to make sure that we are looking at caring children at early age, those the main areas where we can find them. Thank you.
Thank you so much. We'll have to close the question sessions due to time, but these beautiful conversations will even continue throughout the day. I would love to ask Françoise to address the question of inclusiveness. How do we include now children with disabilities? How are they not left behind in on this beautiful journey of ECD as child mental and physical well-being, and the whole child well-being is the focus. To you, Françoise.
Thank you very much. Children with disability have the right to the education, to the health, like other children. And as a psychologist or ECD teachers has to pay a particular attention to them, to see how they grow, and to help other children to do not to develop stigma among those children, and as ECD to prepare the space, the conditions in the house, how to keep them, and if their disability need a specialized teacher or a specialized mental health practitioner, I think ECDs will work closely with those partners to pay attention and to help those children. And those children also are able to study like others, and they can develop easily symptoms, mental health or psychological disorders symptoms, because they feel like they are not other children. And we have to teach other children that those children are like others, have the same rights like others, and also to help their parents through group sessions or other psychotherapies groups to help them to deal with those problems. It's a big issue to parents to have a child with disability. But if a school or if a society help parents, it can be easy to teach children with disabilities. Thank you.
Thank you so much. Going to Caroline, would you please address the question that was asked on policy and practice and how if it's integrated in the community health worker system in schools?
Okay, thank you so much. So yes, we do have an ECD policy, and this ECD policy was revised in 2016, especially to make it more integrated and holistic. So I think that takes the question on integrated, on holistic, and also we have Dr. Anita here from NCDA, and NCDA is charged with coordination of all multi-sectoral, cross-ministerial collaboration around implementing the policy. Because as you know, ECD is not just about only learning or only about health or only about nutrition, it is all the services, and there is not one ministry that can deliver all the services. So that is why we need cross-ministerial and multi-sector collaboration, and that is where NCDA is doing a wonderful job to ensure that all the sectors are well coordinated, the services for children are being delivered. In terms of the implementation and integration with the health system, we have at the community level the health workers, community health workers working very closely with the Inshuti z'Umuryango, the IZU, to support families, especially working on that community health and community ECD programming piece, including parenting education, home visiting, things like growth monitoring, counseling of parents, but also identifying families that need referral to the health facility level. Because the health facilities will not be able to know which exact family needs X and Y, Z, but the health worker and the IZU who visit the family regularly can refer to the right service at the health facility, whether it is mental health, whether it is nutrition, malnutrition treatment, whether it is other services at the health facility level. So I can say the IZU and the health community health workers are the very critical link between the community, the home, and the facility level. And I can say the referral system is working. We have not yet reached 100% if we were to award ourselves marks, but we are on a good journey. And that includes use of tools, early detection tools, for example, for children with disability, identifying parents and families that need additional services like social protection, with the aim of reducing these adverse childhood experiences. And also there is the link to the schools. and the ECCD centers, again through the ISUs and the health workers, and then the teachers and the caregivers at the school, because the teachers and the caregivers at the center can also refer to the health facility. Let's say they notice abnormal behavior that doctor has mentioned. The child used to be active in class, but now they are dull, they are scratching and biting other children out of the blue. That family can be referred to the health facility for diagnosis, for assessment. So this is the way in which, briefly, the integrated services are being coordinated at the, at the facility, at the community, and even at the home level. Yeah, thank you.
Thank you very much. This is a beautiful discussion, but I think this is something that's going to continue as the day as we continue the day. But from what you've heard, this has been a beautiful journey and more is to come. Thank you so much, the audience, for keeping in touch with us since the beginning up to the end of this beautiful discussion. Thank you so much.
Thank you, Nelly. Thank you, Dr. Vianney. And Madame Kalibgende Françoise. Thank you, Madame Caroline Dusabe. Thank you for this interesting and interactive session. Because we're running out of time, we're not going to spend much time outside. So I will invite you, every one of you, to please step outside, get a cup of tea or coffee, and then we immediately come back to follow the following presentations. Thank you.
Yes, thank you. I'm Makile from Humanity and Inclusion. I'm going to share with you our experience, not research, but field experience. Why I care about mental health? As you know, a good mental health is not only about the absence of problem. It's also the ability to live a full and creative life and having the flexibility to face the inevitable challenges of life. Thus, humanitarian crises due to natural catastrophe or political violence affect the mental health of the concerned population, especially the most vulnerable. The WHO estimates that the percentage of persons suffering from mental health difficulties can almost double in emergency and crisis context. While many persons experience stress during and after an emergency, some developed new mental health problems, and those who have previous problems often need more help than before. Globally, 1 in 4 persons experience some mental health difficulties in their lifetime. Mental health problems account for 13% of global illness worldwide. Also, the depression is the most common mental health condition among women and can be more persistent in the women than in men. Women are more likely to seek help for mental health problems. So let us discuss on mental health and psychosocial support for the person with specific need in a refugee camp and host community. Where do we work as humanity and inclusion? As you see in the map, we work where is written humanity and inclusion, where we found the flag. At Chilehe for Mahama camp, at Gatsibo for Nyabiheche camp, at Gihembe for Gihembe camp, for Gichumbi district. We work also to the ETM Gashora for Bugesera district. We work at Gisagara district at Mugomga camp, Huye urban, Chigari. We work also at Nyamagabe in Kigeme camp and at Karongi in Kiziba camp. Humanity and inclusion runs in the refugee camp in Rwanda since 2015. Responding to the specific need of a person of concern in urban areas, as I said, in Congolese camp and the Burundian camp in Rwanda. In September 2019, Hashi extended psychosocial support intervention in Gashola ETM that hosts evacuates from Libya. What do we do? As you saw, you see the pyramid. Our intervention spans several levels for the mental health and psychosocial support intervention pyramid, as defined by Intelligence Standing Committee guidelines of mental health and psychosocial support in humanitarian intervention or emergency. In base from we see that the basic services, this is like a shelter, food, yes. In this we intervene in this part. For community and family support, yes, we work together with the family of person with disability, especially for children with disability, where we work together with the family in services of CBR, community-based rehabilitation. We work also with the family or family member of person who experienced the problem of mental health. For the third, you saw that there's a focus on no specialized support. No specialized support means that we work together with the community mobilizer. The community mobilizer are the selected person from refugee committee. In the top, we have the specialized services where we work with psychologists. We have also worked together with inclusion officers who have the training on the physiotherapy. We work also with OT, occupation therapists. Yeah. Intervention focus on develop health problem and prevention program that address the social determinant of mental health. What we do is sensitization of community, inclusive recreation activities and sports, support community and solidarity initiatives to reduce the lack of services and improve the quality of existing services. There is training for resource person on community-based approach of mental health and psychosocial support needs, training for mental health community mobilizer on case management and the referral pathway, train for services providers. When I say services providers, is the staff of other implementer, other partners working in refugee camp. Yes, we train that on psychosocial support and the inclusive practice. Facilitating community participation to the person who experienced the mental health issues. As the picture showed that, we work together with the group and we make the group in who do all the small business. We work also with the youth in vocational training. We work together with elderly and the person with disability in VCL, means that voluntary saving and a loan association. The person of concern organize International Day and participate in community work. Intervention also focus on to create opportunity to learn about the strategies of improving the psychosocial well-being of a person with mental health issues by adapting the program to the specific need. Here you saw that there is a talent show, sharing space, and occupation therapy activities. Success. What we can tell you as success. The evaluation done by Humanity and Inclusion show that the level of psychological distress for the person with mental health and the psychosocial support need decreased at the rate of 76%. We have also 45 the new small business running by 655 the person of concern in hearing group where both financial and technically supported. 100% of trained disability committee members and the refugee community leaders are able to lead self-advocacy session. So the results are rehabilitation of the house through community work, setting up kitchen garden for the person with specific need and the elderly, providing or provision of NFIs, non-food items, supplemental feeding, and specialized health care. When I say specialized health care, here you have to know that the person of concern who needs the treatment at Tindera Hospital, we help them to go there. We have also other persons who are in Huye Rehabilitation Center, the drug users, the youth as drug users. Yeah, We have also the person who sent at the Kabugai Hospital for ophthalmology services. We have also inclusive education and the removable of physical barriers. The challenge we have many requests from the host community for intervention, even outside the area of our intervention. COVID-19 also stopped the resettlement exercises and setting, as you know, in the refugee camp, we lack the appropriate room for therapy or counseling. Lesson learned. Multidisciplinary teamwork is vital in preventing holistic care. Having inclusion officer, a psychologist, an occupational therapist working together help us to achieve our goals. The second lesson learned is if the person with mental health and psychosocial, psychological issues are supported to develop their talent, the chance of having a quick recovery is increased. In refugee camp, inclusion cannot be possible without collaboration with other implementing partners. I think is what I prepared for you, but as a researcher, when you wanted to conduct a research with humanity and inclusion, I give you the address of person which you can talk or work together. Thank you.
Thank you so much, Immaculée, for this presentation, for telling us different activities for humanitarian inclusion in the refugees camp and the host community. Thank you so much for your great work you are doing in the refugee camp and the host community for improving mental health. Without wasting much time, I will call upon those who will have questions. Maybe they will ask after the presenters. I will reserve time so that you can come and ask questions. I see we have another presenter who works in the refugees camp. I would like to welcome Madam Jenny Abatoni from RPCA Ruhuka, she's going to present about mental health, psychosocial support in refugee camp. We need to learn more from you. Thank you so much. Welcome.
Thank you so much, Samuel, and good afternoon once again to everyone. It's an honor to also talk about our interventions, which are almost the same. When you talk of psychosocial intervention, they rarely differ. It depends on where it is done. But since it is in the camp, they almost resemble, yeah. But as I said, I'm Jen Abatoni from Rwanda Organization of Trauma Counselors. It is called ARCT Ruhuka. So I'm executive secretary, but I'll be presenting one of our projects that we are implementing in the camp. I had decided on this because we have the model there that we are working on, and I want you to continue, please. Yeah, the Rwanda Organization of Trauma Counselors is a non-government organization. We operate since 2004, and in mental health and psychosocial support, over 120 members, and we operate countrywide. Next, please. Yeah, our mission is to lead the development and application of innovative approaches, strengthen professional capacity, understanding and preventing and treating psychosocial problems. And our vision is a Rwandan society where people are psychologically healthy for durable peace and sustainable development. Next, please. We have 5 strategic goals that we serve: innovative mental health and psychosocial support, peace building and reconciliation, where we do healing for reconciliation, family conflict prevention and management, research, documentation and advocacy, and organizational development. So I wish to see our participants here or today's symposium feeding into our research and documentation and advocacy work as we practice together. Next, please. So our model in the refugee camps, especially being a humanitarian setting, it is an integral part of whatever we do, and mostly even with other partners in the camp. As my colleague said, in the camp you don't work alone. There are many people assigned different programs or different target groups, and you work together. Some are in education, others in psychosocial, others in social, others in health, others in WASH. So you come together to make a big team, and you are coordinated at camp level. So our intervention, we went there because there is a need, especially for individual counseling. By that time, we shall sit down. Our model is community-based, and we work with refugees, of course, where we train community volunteers. So next, please. So the model, how it came, is that in the camp there were different interventions, including sociotherapy, psychosocial work with groups and families. So, but there was a gap for individual counseling. Here also shows a baseline that was done in 2016, where we had suicidal tendencies at 16%. Oh yeah, suicide attempts. Suicide plan at 18, and suicide, I can't see. Suicide what? Did they commit these ones?
Yeah, suicidal risk ideation, 13%.
Ideation, plan, and attempts. Yeah, attempts at 15. So by then, it was 2016, and really it was bad, and it was found out that there is need for looking at individual rather than a bigger group of people, because people have different issues, and we had to address individual, couple, and groups of people in the camp. Yeah, next, please. So our work also involves, of course, having people based in the community, where we select community psychosocial workers, we train them, and then they are part of the refugee community. They provide services. Next, please. The pyramid is the same. There are communities we serve, trained community psychosocial workers, they are counselors. We normally have a counselor at each camp. We operate both in Mugombwa and Chijeme camp. So each place, they have their own counselor or psychologist who is specialized in that. So after that, we refer to the specialized services. Next again. The major services includes awareness raising, training of community psychosocial workers, as I said, providing counseling services, including individual, couple, and groups, referral of difficult cases to the counselor in the field, provide care for caregivers or those community psychosocial workers, or provide clinical supervision to the counselors, and support, especially for their own support, because these people are mostly also affected. So some of them also do get their own counseling, but also they get support to support other people, especially to ensure the quality of services. Next, please. Yeah. What we do, we work with, maybe I didn't put target group, but we work with women and families as well as youth. So part of the youth, we do what we call retreats, where we bring youth together to talk about the issues they are facing, but also to support each other. And we train teachers, especially in the camp and outside the camp. We provide refresher trainings to community social workers. And this is because most of the time, even if we train them, they go to the field, they meet different cases, and they want more training. So we normally keep training them. And then we train trainers for sustainability. We normally put what we call peer-to-peer support or training of trainers. Yeah. Next, please. Lessons learned. Working with community members or community members, especially within the communities. It is really a good thing for sustainability, especially when you train the trained community workers who are based in that area, they still stay there for continuity of the activities. A combination of counseling interventions, counseling for individual, counseling for group. We have seen that people cannot, sometimes they may not open in a group, but they open better in individual. Others don't open individual, but they prefer groups, and so on. So this has worked. Next, Joseph. That one is about one of our success stories. After training of community workers, some of the refugees, specifically in Chijeme camp, they had a hill where they used to go and grieve and cry and all that. But after training, they got counseling, and they have people at their quartier, so they no longer have to go to that hill. They have people who are trustworthy around them that provide counseling services. Next, please. The major issues we meet in the camp, there is family conflict and intimate partner violence. There is a lot of GBV or SGBV and teenage pregnancy as well. There is drug abuse. Of recent, we have had theft and witchcraft. I think this psychosomatization of some people who are having issues also. But you hear the whole camp panicking that there is a lot of, someone who has witchcraft me. So you find the whole camp really sort of panicking. There are suicide and suicidal tendencies. There is transgeneration trauma. We see many youth having issues, and when you go deep into the discussions, you find they are worried about the life of their parents and how they were brought up. This is characterized by all those things. Next, please. Challenges includes COVID-19, lack of safe space. The camps are really open space. There is nowhere to hide. Sometimes our community workers have to go under the tree or use some centers or some offices, but people keep moving inside and out, so it's not safe at all. The camp population is too big, even that the trained community social workers are not enough. There is no identified collaboration especially from camps, on mental health, from camps and outside the camps, how to refer to the hospitals and back and forth. There is also no joint mental health activities. for both refugees and host communities. And most of the time, the camps, the people in camps, they face violence outside the camp. Sometimes there is a lot of conflict due to concubines outside the camp. So there is need for joint mental health activities for both the camp and host communities. Next. Proposed strategies and maybe research areas, if I would say. Research on impact of mental health, of COVID, on mental health and psychosocial support. Research on transgeneration trauma within the camp and the youth. Development of clear partnership and collaboration among partners in the camp and also in the host communities. Expanding joint mental health and interventions for refugees and host communities, especially how can we build space together where they can meet and discuss. This also helps them to feel like, you know, they are included, they are also taken care of. Provide safe space that is confidential for counseling as well. I think that is all. Next, is there anything else? No, thank you. Thank you so much. I think that is what I had to say. But going back to the community psychosocial workers, their work mostly is to listen to people, but they also do home visits where they go teaching people. And we have seen many young girls getting pregnant. So the issues in the community, in our communities in Rwanda, is almost the same as, you know, when we talk of teen pregnancy, when we talk of malnutrition and all that, you find it is the same as in refugee camps. Thank you so much. Yeah.
Thank you so much, Jenny, for this great presentation, for telling us different interventions of ILCT Ruhuka in the refugees camp. It is really informative that you contribute more in the mental health of refugees. I keep reminding the participant that keep writing somewhere the questions. Maybe you have interest to know how, I mean, in refugees camp is the place where also being even refugees is a cause of stress. Maybe you will ask them how they integrate their mental health on the child development. So I would like to call upon the next presenter. He's Dr. Shaste Uwihoreye, is Executive Director of Uwisengani Manzi. He's going to talk about supporting children and youth people in the victim of broken society, re-enhancement community parent responsibility. Welcome, Shaste.
Thank you very much, moderator, for this time. I would like to share our experience. It's just experience, it's a practice, it's not a research. It's an experience in working with children who are living in the street or who are street-connected children. And this program is a program we started just in 2017, where we were just questioning the way children were supported. For Rwandans who know how they are supported, mainly children, they are rescued in the street mostly by police, and they are placed in the transit center, then the rehabilitation center, and they pass there for a while, and then they come back in the families, in the community. And then we were asking the question, because when children are living in families, they may have something wrong there. There's something which is not good there for them. And we said, maybe we can do something supporting both children and parents and families and communities. So with my presentation, we are going to, I'm going to share how do we deal with children and how do we deal with families, parents, before reunifying children in the community. Next, please. So this is the background. I will not go emphasize for the research done by National Children Commission. I think in 2012 that the recent research done by government. Around 2,000 children were living in the street, and around 52% they were taking at least drugs, and 53% were just living in the street full time, day and night. Others they can, and we know the divorce problems, and we know the problem of for rehabilitation centers. And now they receive more than 4,000 younger people a year. Now the government opened a new center in Nyamagabe, you know it, which also receive around 3,000 younger people a year. So it's a big challenge. Next, please. That is what I talked a little bit about. Just two different programs, a healing program for children and another healing program for community and for parents. Next, please. There are three phases we go through. The first phase is a little bit of assessment, exploration, and the second phase is a healing process, and there is another phase which is graduation. How we know that really a child who was in the street is really, and they are combined by those healing sessions. How can we get resources and the coping strategy, building confidence, ambition, and changing behaviors of children. Next, please. So we have already, if I can say, identified, created with children, with community. If I can say, contextualized exercise and practices which are child and youth-friendly exercise, which we do use in exploration. Most of the time, when we are talking about screening, sometimes the screening tools we do have, the checklist, we know there's so many checklists we know in mental health, sometimes are not working with children, and sometimes are not working with our context. So those are some exercises, starting by naming a problem, knowing what is it, how can we name in our Kinyarwanda. You know, in mental health, even we don't even have a concept. We talk about depression, trauma, anxiety, all of those names. Sometimes we don't know, we don't have those names in Kinyarwanda in our context. Even in addition, working with children and young people without those contextualized concepts and names, sometimes it's not easy. So those are the different names, exercise. I cannot go one by one, but we have a module which detailing each exercise, each practice, how it is being done. Next, please. I will a little bit talk about few of them. This is one of naming a problem. This is a session that help children and young people to get emotional insight, emotional understanding of what happening in them, and try to structure a kind of problem which is internal. And loving being me, it's an exercise which helps children, adolescents, a little bit to know something good for them, which is remaining. Because most of the time, those children, young people, they are called, sometimes when I went to Gitagata in one of the rehabilitation center, I asked, what problem do these children have? They said, a behavior disorder. All of them, they have disorders. And our methodology, our practices is not more pathologizing. Is not more pathologizing. Is just giving a name. Next, please. This is another exercise, which is a tree of life. It's one of the exercise used in narrative therapy, Gitichubuzima, where also it helps children to reflect on their ambition, the future, when they are reflecting on their fruits, what will be their fruits, but also it can also to explore the if I can say, the problems. When I'm using like a metaphor of pest and pesticide, a tree can be destroyed by pest, and when because this is when we draw it and it become a child, we can explore around it. Next, please. But also we have a number of exercises which help children to heal their problems, to cope with their challenge. This is an example of umbrella of problem. It's a metaphor we use when we draw an umbrella with a rain of problems, orphanhood and whatever, poverty, and then under we can see how can we get an umbrella of those problems. This is a garden of hope, a journal for all those is a number of exercises we have been produced to support children. Next, please. All of this are the exercise. Next, please. I don't know how. This is another exercise, team of life. It's another exercise used in narrative therapy. Next, please. Just a little bit to share how we are structured here in Kigali, because this program is being used here in Kigali and in Rubavu. You will see we are having now 115 former street children who are reintegrated back in 12 schools here in Kigali, both primary and secondary schools. And we created at each school a group of students, between 15 to 20 students. That's a group, mixing both former street children and the other children. And they have to, in each group we have 3 facilitators, a teacher, and 2 kids and 2 children. And those 3 facilitators, they are trained in those exercises, how they can facilitate their colleagues, and they are given a program. They meet once a week, but those 3 facilitators, they meet our psychologists once a month, just to monitor, to see, and each school is visited once a month. That's a little bit how it's structured in schools. Next, please. It's a lot, but those are it's almost the same in Rubavu. Next, please. This is just they keep exercising at school. Next, please. So trying to to summarize a little bit our model, trying to summarize our model, you see our healing process go from 1 session to 7 sessions just before being graduated, and it goes through, if I can say, 4 steps, which start by building trust. You build trust, you find the strength, you find the resources, then you heal bonds between children and parents, and then you build resilience. And that is a process. Next, please. This is maybe a chart summarizing our model. A little bit, even if I'm saying it's an experience, it's a practice, but it should be even a kind of, if I can say, a circle, which is should be compared as an action research, because we learn, we reflect toujours, we reflect every time, and then after reflecting, at that session we had with facilitators, we make a plan. A plan is how we can creating settings in schools, creating settings in the community. We inform students, we train them, and then we create those a group. And then we keep exercising those exercises we have been created. It's just once a week. And then we're questioning at every time personal change among participants and reflect to the next tool. If we use maybe a tree of life, which another tool can we use? And then we continue to observe. And it's a circle. Next, please. So the second category is a healing process for community, for parents, which is, as I said, trying to change sometimes the mindset. When you go you ask parents, kuki umwana yagiye mu muhanda azakubwira ngo cyarananiye. Sinzi niba hari uwo mwaganira. Cyarananiye ni ikigoryi. He's the one who is the problem. So we start really to see who is responsible. Is it a child? Is it a parent? Is it a community? Who is responsible? And we try to be at the side of children. But also for them also, they have problems, even the parents and the communities. We go through the same process of discovering and naming what problem they have, and then they go to those healing sessions and finding resources to take responsibility for their children. Next, please. So next, we have also a number of exercises that the parents go through. Next, please. This is a name of problem. You see some drawing even done by parents. Next, please. Sometimes we use the same exercise. Next, please. Next, please. Next, I know we don't have a time. Next, we talked a little bit about the umbrella of problems life. We have a group of parents in the community. Next, please. Then after the parents, they go through that process from exploration, healing, and graduation. After the children go that process, it's where now we start the reunification to put again to children and the parents, where we do with local leaders and UNM staff just to make a kind of follow-up. Next, please. Sometimes we do home visit. Next. That's a plan, the same I presented with children. With parents also, we have a plan in their community groups. Next, please. Next. This is even the parents also, they keep exercise. Next, please. It's the same as we do with children. we do also the same circle with parents and the community. And at the end, before we identify children and parents. Next, please. So exercise, of course, have been created, and they are supporting the healing process just to facilitate this effective family reunification, so that we can really a well-being family with a cohesion, and we strengthen this relationship and attachment again, children and the parents. Next, please. Those are some tools. You know, most of the time we create tools and we borrow tools from outside, but parents and children, they are expert. Those are some of the tools they created for themselves. Either songs, either poems, either architecture, either group of exercise. They create themselves, or they are using for themselves, and they are helpful. And sometimes we think, I'm a therapist, I'm a clinical psychologist, I'm the one who can create a tool. Sometimes the children and the parents, they are expert and they can create those tools. Those are the numbers of different tools which are being created by parents and children themselves that help them and that are helping others. Next, please. This is the outcome, numbers of children now from 2018 up to now, which have been reintegrated back to schools in the community using that approach, that model. Maybe I will not talk about numbers. Maybe Joseph will share the PowerPoint. Next, please. This is also the outcome. Next, please. This is the number of groups which have been created. This is a number of outcomes showing how the experience is supporting people. Next, please. Sometimes we also do social support, providing school materials, providing food, but also some between themselves, they support between them. Next, please. I think this is the last slide. Thank you very much. I took a long time. I'm sorry.
Okay, Shasta, thank you so much for this great knowledge and the great practice you use and you do in your institution for helping the children, not only them, but also their parents, so that you can not only help them to heal their mental health, but also to build their resilience. That's very nice. I keep saying, please record questions, because this is very interesting. We need to know if there is some research has been done on this, so that it can be disseminated and others can apply this. So keep having those questions, so that I will give you time to ask. We are going to, I'll ask Joseph. Okay. Yes. We are going to welcome Dr. Eric Ndushabandi. Is the Executive Director of RDP Rwanda. He's going to present about mobile arts for peace in education and mental health support for peace building in Rwanda. Kindly welcome.
What I'm saying? I guess there are some people online speaking English only. Yeah? Okay. So let me present my excuse first of all for coming late. But this was due to the TV show. I've been accompanying the visit of Macron here in Rwanda. So I've been to television from 9 up to now, so I'm tired. And from very, very political perspective, I'm going for mental health. So I need your support, first of all. Good, I'm Eric. I'm teaching political science at the University of Rwanda, but I'm the director of the Institute of Research and Dialogue for Peace, which is known as a think tank and a peace building organization. I thank you, organizers, my friend Vincent and colleagues. Austin, we have been exchanging very much. I salute and thank you for accepting this presentation. Just a brief experience. And I'm happy that I've been flexible to bring my presentation after Dr. Shast, because Shast is my friend and my partner as well for this project. Okay. Mobile Art for Peace. You can see it as one of the projects we are running in a peace building at the Institute since 2018. It have been starting education, health support or psychosocial support to people, and all resulting to peace building and social cohesion in the families in Rwanda. So it is very easier to talk after Dr. Shast, because many things have been said already. I'm sharing how we bring research to be very practical. And from practices, you collect evidences. And from those evidences, you heal, you give space, and neutral and independent spaces where people can express their trauma, and then leading to psychosocial well-being, offering support to people. A mix of research, peace building, psychosocial support, and everything. It is mobile because the approach can be adapted to many and different ways, and for different categories and for different purposes. This is why it is very mobile. It is based on local cultural performances. So local and the traditional practices are very valued here. I will come back to the research framework. This is music, dance, drama, drawing, painting, poetry. We are integrating in this process. It started that year in 2018 in Rwamagana, Eastern Province, in 5 schools. Then it is being extended in 5 districts in a community dialogue, because IRDP is known as engaged in grassroots approaches, engaging people in community dialogue, and the youth clubs in schools. So MAP is being infused in all those structures. What is it about exactly? It is mobile, but having these elements, which is very holistic. Units articulated in the manual. The manual, we have it in English and in Kinyarwanda from Lincoln University. Professor Ananda, who is the author of the approach, but working in many countries already. Nepal, Indonesia, Kyrgyzstan, and Rwanda. It is addressing trust building. Iyo tuvuze ngo abantu batakaje icyizere, confidence. So the approach can address all this: trust building, teamwork, being with others, active listening, improvisation and creativity, image theater, characterization, conflict analysis, dialogue, problem solving, leadership, adaptation and innovation, research skills. Here, research skills given to young people especially. It is all related about the critical thinking, but we use it in a toolkit, a specific toolkit, where we initiate young people for analyzing problems, formulating them, communicating them, even bring them to the table of decision makers. So we said we are partnering with many people, many institutions. It has been expanded to what we call Network Plus project, which is engaging MAP in a community dialogue using those approaches. So this, we are working with Minalok already in those districts, and we intended to escalate and to extend in the main district. Then it gave another project. I quote here Dr. Shast as well, my colleague, where we reflect this, and we say the MAP can be applied for mental health. This is what we call MAP at home, because it is going to individuals and communities. Here I've been talking about teen mothers and former drug abusers, addicted. So we called it Do It Without Wisengani Manzi, which is specialized in this work. I mentioned here story circle telling, very important, because we give space to people to heal, to express their emotions. And this is a very productive way. This is very big work. We work with REB, Wisengani Manzi, RBC, and RS, Nick, Kwetu Film Kigali City now, very soon, in these ways. I think some examples have been presented and well explained by my colleague, Dr. Shast. All those are kind of therapeutic exercises. We can see it in concrete ways, which end by being tools for data collection for research. Evidence-based, art-based research, it is very practical. It is not just theories. It is a shift from traditional ways of working. If it is not in the domain, but maybe in IRDP approaches. What can art-based approaches? We started by research questions. And let me remind that MAP at home came during the first lockdown. So it is in a COVID context, where we thought it is very important to offer some support to people. So what lesson can be learned from this online arts programs to shift and bring people who are suffering psychologically to online? It has been a specific journey, which is very informative. So how might MAP at home advance digital innovation in the design or delivery mental health provision and the response services in Rwanda? So the context is making people to reflect deeply. The objective is to provide online arts-based workshop to enhance psychosocial well-being, and which is very well led by my colleague, Dr. Shast. To create a child and youth-friendly, he used already this concept. Those lessons have been developed by my colleague Shast and all colleagues in the project, but to promote resilience in schools and in community settings. This is creating a network between different organizations. We need artists, and an MOU have been signed between IRDP and the Ministry of Culture. The umbrella bring together artists for this, and all educators and organizations working in these areas. It has a research framework as well. We draw it from performance studies, which is a not very much developed domain here. Childhood studies, yes. Dr. Shasta have been elaborating on this. Psychology, cultural, and critical branches in this work. We are here at the Center of Memory Studies, because we are bringing young people and educators and the parents. So this is intergenerational memory. Anthropology, but also a wide contribution, to a wide domain of global mental health debates. All this for peace building and social cohesion. We use the same methodology as we use in social sciences, but from very practical, this panel was very well titled. Practices as research and using How much time I have? Oh, okay. By the way, no one is giving me the minutes. Okay, let me go quickly. I'm going very quickly to the findings. So we co-produce knowledge together. This is very important with the research subjects. And it is very participatory. You have to engage with people, not participant only, but main organizations. We use the same techniques. Decolonizing, it's very important because it is based on local practices. You can't go for practical research if you don't engage with local and embedded in culture and traditions locally. So practice listening, observation, journal, we note everything. Stories of changes are reported. And if important, we complete it with interviews and questionnaires in this way. Then images and the video. This is very concrete. You can see it on this, how it is practiced. And in these settings, we have psychologists, we have artists, we have researchers, and those specialized in all these businesses around. So we brought it online in a COVID context, and it works very well. Just to distribute phones to people, and trusting that people will take care of phones in a COVID and a crisis context. So we have a pool of master trainers from schools, from communities, but also from university, even Kie College of Education. We have a pool of people and young trainers, then artists, as I said. So the activities have been very intensive in this period, bringing all these people online, organizing, first of all, training, rehearsals, workshops on very well-designed content. Then, if it is a research project, but it is an intervention project as well, this is how it is very well complementary between Wisenganimans and the IRDP and others. So producing articles, journals, the pool of researchers are writing continuously, collecting data, and abstracts have been accepted already. We are proceeding in that way. So when we talk about lives of people, it is about concrete cases. What is bad and what is good in their lives. Bad experiences, you can see it from up and down, how people can represent and draw the pain and the trauma they face in their lives. So indicative findings, to go very quickly, those are some testimonies, just a few to indicate how online, how this bringing phone to people is bringing trust to people, and people are valued and they can engage. So I think the psychosocial support start by bringing to people this trust and the confidence in their humanity that they can serve in their societies. So what they represent in the families and the feelings they have toward neighbors, direct neighbors, or how they are seen in the society. People are shifting from there. All these testimonies are painting one step of hopeless, of depression. Then the second step is presenting people as confident after this work is engaged. Those are teen mothers from both sides. People who are testifying that they can learn from their failure, and they can trust that they can trust the future and be active citizens. So for people who are interested, you can share all these testimonies to show you how it is very empirical and concrete. Drug abusers, of course, from depression, testimonies are given. Then how songs, poems, dance are contributing to the healing and bring confidence and well-being. Testimonies are coming in the way people are unanimous that this approach is very, very useful in helping people. That issues which are affecting people can be addressed through these art practices. But as well, advantages of this approach, you find the people in their places, and you can use less resources. And when it is about pandemic or catastrophes, you can assist the people online and support them, because psychosocial support is not needed at the end of catastrophes and the pandemics, but during. So this experience we are sharing here, the benefits, everyone can imagine how these have been very helpful for people. But many challenges as well. How this model can be duplicated, can be used in the future. The problem could be the network infrastructure and the availability of people, trusting the people that they can own all devices and be used for the project, be used for really supporting them. In many countries, in the catastrophes, in the war, you can pretend to use this approach, but internet can be cut off. You have been assisting it in some countries. So we are conscious of the limitation of the approach. But where Rwanda is a model in technologies and infrastructures, it shows a good experience that online at base can be used as an approach in supporting people. So it is not easy or to monitor emotions by distance online. I hope Shast can respond to some of those questions. How are we supporting people? Because the exercise of maps themselves are bringing some emotions. So how do you support, how do you ensure that oral or verbal expressions are captured when you know that he can switch off the camera, or he can just keep quiet behind the screen? So people are suffering after the exercise, but as well it can be used as an approach. So I thank you very much. What lesson can be taken from this experience? And who want to join? I could wish everyone can join the initiative. We still have a few schools, a few communities, and the demand is very high. Thank you very much. I appreciate it, Dr. Prof.
Thank you so much. Thank you very much for this great presentation. We really think that mobile, it's maybe it's for calling, but within this presentation, we have seen that mobile can not only working on calling or messaging, internet or what, but also contributing in a peace building and the mental well-being. In our program, we still have a presenter before we enter in a time of discussion. I would like to call Dr. Jean Bosco Niyonzima from Ubuntu Center for Peace for coming upon here to present about tracking trauma and other common mental health disorders through the community-based social healing model. We can't request, because of the hours or because of time, we can't request to squeeze the time. Thank you.
Thank you very much for this opportunity. May I ask a favor before I start? I would appreciate if you could stand up for a few seconds and practice one breathing exercise. All right. Should I stay here? All right. Jean Bosco Niyonzima, I'm a medical doctor, but I currently work in the community with Ubuntu Center for Peace. And as you can see, our goal is to really create healthier, happier communities by helping trauma-affected people to heal. So I really wanted to share with you the results from our mid-year evaluation of our community-based social healing program that we are implementing in Kamonyi district. And maybe a little bit of background. We started our program in Kamonyi district in June, July 2017, where we recruited 80 community healing assistants, trained them in the notions of trauma and basic notions of trauma and common mental health disorders, and supervised them. After they were trained, they went in the community. They recruited the people who had symptoms and formed healing groups of 20 people each group, which they facilitated for 15 weeks. The preliminary results were very encouraging, as you can see. And so we decided to move to the next phase of the pilot. So here we looked at some symptoms like suicide, like absent-mindedness. But in the next phase that we are implementing now, we are looking at syndromes, either PTSD or depression and anxiety disorder. That's what we have evaluated recently. Now, before I move to the evaluation, I wanted to explain a little bit about our model. So in the context of, in a humanitarian context or in the aftermath of a large-scale traumatic event, you have mainly like a collective, not only individual, but also collective trauma. And the biggest challenge is that many people don't have access to trauma services or other mental health disorders. So they don't have care or services. And even if they did, we have our conventional healthcare system, which is individualized, mainly individualized and medicalized system. So that's good, but not sufficient. So our model wants to complement the existing system with 4 elements. The first one, it integrates movement therapy, collective narrative practice, which is specifically the use of tree of life as a tool to help people to shape their stories, but also it's used as a symbolic, as a metaphor for healing. And the third element is rituals, and including traditional dances, actually. The second thing, this is mediated by community healing assistants, whom we recruit from the community. We train them and supervise them to provide these services to people who need them in the community. The third thing is that this community healing assistant, they recruit people who have, either trauma or other mental health illnesses, common, and then they form healing groups. That's very important. We do everything in the groups, but the group is limited to 20 people, and then they meet once a week for 3 hours for 15 weeks. Actually, we have some similarities with Dr. Shast and Eric, because the first 7 weeks we focus on creating safety and trust, and then the rest they delve into the story sharing, telling in smaller groups. Now, the fourth element of the model is that those therapeutic groups transition to long-term support groups or self-help groups where they create new activities, either it's solidarity work or loans or cooperatives. Now, this is a kind of summarizing our model. Now, the results that I wanted to share with you are from the implementation of the program that we implemented since last year, August, where we recruited 120 community healing assistants, and they went and trained them in our model. They went in the community. They selected 1,200 people whom they accompanied for 15 weeks. We did this in Kamonyi district in 3 sectors, including Rukoma, Nyarubaka, and Msambira. And we did both baseline and endline. Baseline in October and endline in March. The questions that we had, of course, the goal was to make sure that we have a reduction of at least 50% of, symptoms in depression, PTSD, anxiety disorders, and psychosomatic, but also the improvement of quality of life and reduction of disability. But we assumed that this should have an impact on the work productivity and family at large. Family reconciliation, reduction of domestic violence, and children school attendance. And so these are specific questions that we wanted to understand if we have achieved them. So the collection of data involved clinical psychologists. And our data collection tool was set up in Kobo Toolbox. And the data collection tool actually, I would say not data collection tool, it's like a both screening and monitoring tool, combines many tools. We have many international neuropsychiatric tool from DSM-4. We use that because it was validated by the University of Geneva and it was used here in the screening prevalence, evaluation of the prevalence of PTSD in Rwanda. So, but we used as well to measure the severity of symptoms. We used the primary health questionnaire for depression, the questionnaire for anxiety disorder, and also the PCL5, like a post-traumatic disorder checklist by DSM-5. And then we used as well the WHO 26 items for quality of life, and WHO again 12 items for disability. Now, the data analysis was conducted by like an independent consultant, but we used Stata 14.2 version, and we did 2 types of statistic tests. We had limitations, and using like on a sizable data, using like a professional psychologist, it's really expensive. And maybe later we'll look into, we'll see if we can recommend something more concrete and more feasible. And also, this, we had people who missed appointments on the day, the collection days, data collection days. And because we had to analyze the pre and post intervention on people, and so we had to look at the payers if they are complete. So if we had missing data, we would not consider people. So from 1,200 people who were enrolled initially, we had 1,062 people who completed the 15 weeks journey. That's a good number, like 88% of retention. And only 942 were considered for statistical analysis because they had complete salary or paying jobs. Now, this shows how the intervention, the effect the intervention had on depression, anxiety disorder, and PTSD. And as you can see, it's we had a very statistical significant improvement. So from like around more than 54% of depression healed or improved, more than 63% from anxiety disorders improved, and more than 70% of PTSD improved. If you look at the severity of symptoms, here you can see how those who have major or severe depression or anxiety disorders have really improved. Now you have, when you look at the psychosomatic manifestations, we have a significant, like a statistically significant improvement in all psychosomatic manifestations. Now, let's move to quality of life. So we looked at like the 4 dimensions of quality of life. Physical health, psychological, like social relationships, and environmental quality of life. All of them have improved, statistically significant. Now, we move to the work productivity. So we considered both the overall disability, but also on the lost days. And you can see the overall score for disability has a statistically significant improvement, as well as you see the lost days. It's also significant. For the lost days, here you may see, for instance, from the median 5 to 3 interquartile range. Okay. Now, this can help you to understand better because it's in terms of percentages, looking at how people have improved in their ability to work. If you look at the absenteeism and child school attendance, so we have recorded like a 27% of children going back to school, despite COVID-19 context. We would expect that number to go higher in normal conditions. But also we looked at the domestic violence, and this has been overwhelming. Like you had around 367 cases of like a couple family violence, and people have healed and reconciled. We only had 107 who are still struggling, but it's a journey. Now, conclusion is that our community-based social healing model works, and the evaluation suggests that we have even exceeded the expectations. But given the limitations and struggles, we think that moving forward, we want actually to validate the tool in the community so that moving forward, community healing assistants, when they are trained well, can themselves collect data on regular basis. Actually, this is linked to the last recommendation because we wanted to collect the data before the intervention, 8 weeks later, and then after the intervention, and 6 months later, and 24 months later after the intervention, because we want to make sure that the gains are maintained or sustained. Also, we need to try the use of technology in community healing assistance, and hopefully we will have partners. We find partners to work together to prove the efficacy of the model and advance scale up. Movement therapy, narrative practice, and rituals in the community, by and with the community, gives us hope that there is a light at the end of the tunnel. Thank you very much.
Thank you so much for great presentation. I'll turn from trauma to self-help group. As he was presenting, he was showing us within his presentation how his intervention has contributing to the participant from Kamonyi, and then they live from trauma and they reach to self-help group. So we have, maybe when one participant is speaking while we didn't give you a speech, sometimes it's yeah. So this is why we are going to have a panel discussion for all different interventions you have been saying here in these sessions. There are different interventions has been presented by Waisengani Manzi, HI, ICT, IDP, let me check well. Yes. IRDP, thank you so much. So main intervention and intervention presented by Jean Bosco. So all those interventions, we are going to think how are those interventions are collaborated. How do we work together with academic institutions so that we can have a good impact on development of children. Not development physically, but also psychologically. This is the reason why I would like to call a panelist to come here after we have this panel discussion. I will quickly give you the questions. I would like you, maybe we can start with the panel discussion because some of your questions will be replied with the panelists. I know it's, yes. This is my great pleasure to welcome here Professor Letizia Nyirazinyoye. She's a full professor from University of Rwanda, School of Public Health. I'm lucky that is my lecture. I'm also happy to welcome Mrs. Jeanne Abatoni, Executive Director of ILCC Ruhuka, and Dr. Shast Uwihoreye. Then we sit here and we discuss. We discuss on the topic. We discuss here on the topics called fostering action research, partnership research with the local community in Rwanda. I wish we can do this discussion maybe before we go in the lunch, because I know it is really touching to this presentation we have been doing. Kindly help me to have mic. If Joseph help me to make sure everyone has mic, so that we can start discussion. And also, I think I would like you to note some question as I keep saying it, so that if there is No, there is some question not replied by those three experts. Experts, maybe you will come to ask to them. Okay. Yes. From the morning, we have been talking about child development. We have seen different presentation of different speakers about child development. We have seen different research and institution. There is some questions maybe I have been thinking that we are going to discuss. I would like first to start with Professor Letizia. If she can share us about successful stories of informed research in various institutions and impact on development of local communities. If different research which are applied, maybe in a college institution, if those research has been impacting our local community in benefit of child development, not only physical, but also mental development. Thank you so much.
That's a hard one. So good afternoon again. In terms of success stories about how research has impacted early childhood development, in fact, some of the interventions or policies we have in Rwanda, most of them, they started as a research project. They were a collaboration between NGOs, the government, and academic institutions. And after testing them and assessing their impact on communities, they were scaled up, and some of them were integrated in existing structures, meaning administrative structures, as national programs. For instance, this community-based insurance, health insurance, what we call mutuelle, it has a great impact on early childhood development, as it has contributed to reducing child mortality, maternal mortality, and this has a direct impact on early childhood development. We have seen how children are taken care by mothers, and we all know that without good well-being of mothers, good health conditions of mothers, how it affects not only children but also fathers and other people in the family. So this community-based health insurance is one of the tools that have impacted the health but also other sectors of our population. And it started as a research project. It was testing a model from elsewhere, and it was piloted in only 2 districts. And once it was found to be successful, it was expanded to more districts until it became a national policy. And this is just one example on how it can be, how some research program can impact early childhood development. And there is also another kind of collaboration that starts as a national program or as interventions by NGOs. And because academic institutions, because students or researchers have known them, they design research, they mobilize funds, and they make it known. They test these models, and they can be, once they are published, they can be adapted to other settings and also being implemented. So this is one of the success stories. Beside the community-based health insurance, there are also these nutrition programs that are done at the community level. But I have another example of one of my PhD students. She's a mental health nurse, and she conducted a study for her master's on perinatal depression. This is depression for pregnant women and new mothers. And she found that depression was very high among these women, and there was no structure to help them. And it had impact on the newborns and child development. So now she's doing a PhD using an intervention at different levels. At the community level, with the collaboration with the RPCA and the Ministry of Health, we have tested a tool which has 3 items to detect depression. So this one, community health workers will be going around in the households and they will ask 3 questions. And if the woman replies, I think scores 2 out of 3, then she will be referred to health centers. And the health center nurses, they have also another list of 9 questions that were adapted to our context, of course, and translated into Kinyarwanda. They will ask these women in OPDs and also ANC clinics. And so this is how mental health is being implemented. And these women, if they score positive, they will be referred to specialists in the community or even sent to district hospitals for treatment. And they will be referred back to health centers for follow-up. And this is aimed to have an impact on children, on babies during pregnancy, around the delivery, and also there will be a follow-up on the outcomes in children in terms of growth, other health conditions, and also cognitive and emotional development of children. So this is one example on how research can inform policies, but sometimes what exists, like existing policies and interventions, can also be research topics for academic institutions, and the reason for collaboration and mobilizing funds for action, and that will help early childhood development. Thank you.
Okay, thank you so much for these great answers, and I think it's well structured. Then there is another question. Maybe I can keep asking you. You know, during the morning presentation, here, remember, we are thinking about institution and child development. There is some findings we have seen that maybe we need, there is a, from your presentation, we have seen there is a challenge of ignorance. There is how we need our children should be developed mentally and physically. And also there is some interventions. We are thinking, does our institution, our academic institution, does have those discipline for helping maybe the NGOs, helping the community so that they can get the workers who can be qualified on helping the child development?
From my experience, from early presentations and discussions, we were saying that early childhood development is a holistic approach. So it doesn't require someone who is specialized in child development, but it has to be integrated in all other sectors, in existing policies and interventions. But it also needs everyone to be involved, be it fund mobilizers, be it policymakers, be it stakeholders, parents, even children themselves. We want them to be stimulated and, nurtured so that they develop and they reach their full potential. So how I can see it is not having a program focusing on early childhood development, though it may be useful, but I would go by having early childhood development integrated into mental health programs, clinical psychology, public health. We have students who are doing their thesis on early childhood, and others are doing it on mental health, but they are in School of Public Health. We have our colleagues from the College of Health Sciences, but you can integrate early childhood development topics or research or components in economics, in political studies, in gender studies, in everywhere. So this, and in programming as well, we need our policymakers, our planners, our NGOs to integrate components of child development in all they do, so that parents are informed, teachers are informed, nurses, social workers are aware of the needs of children and how they can be integrated in all they do. Thank you. Maybe my colleagues can add on it because they're the ones implementing.
Good. Yeah, yes. There is another question I have been preparing maybe to ask Jane based on the presentation, even the topics of today. As you see, there is different interventions which are in place for helping the children, for helping the family, the community. There is a family-based institution, there is NGOs, there is. Do you see the partnership between these institutions are enough so that we can protect the children and protect the family? Even you can refer to the experience in the refugee camp. Thank you.
Thank you so much. Thank you so much, moderator. I think there is really a big gap between the practice, the research, and supporting the communities itself. The practices that we do, they still reach small community, small portion of community, then the research. And this is shown in even here. Even if we talk of action research, you may find it is only 1-2 organizations. And they do it alone, and there is no coordination really between what they are doing and other organizations, and maybe if it is government institutions, it is that one. If it is an academic institution, it is that one. And it stays there. You fight with, implementing activities, but coordination is really still missing. There is a big gap in coordination of different researches because, or even practices, like we may be implementing a project, but nobody knows. It is known by district of Karongi where we operate, and nobody will know. We do a baseline, we don't present it to somewhere. Someone will come, and this sometimes causes duplication of work, especially in some places. So you find it is the same work that is done in different, maybe context, but same almost. So there is really need for coordination. Especially, I wish that this could be a chance for academic institutions, researchers even, to also come to the field and try to incorporate or even carry on the actions that we are taking to accompany it in a research action. The same as our practitioners. I think it is high time we think of collaborating with universities, with researchers, so that what we do is really being documented. We are still in analog the way somehow. You try to, for us like NGOs, you do baseline, you implement, you document success stories, you report to donor, and that's all. You don't care about, there is an impact, but you don't show anyone. You don't need to sit here and showcase that you have done this and that. You just report to donor, get more money maybe for expansion of project, but you find really it's not connected anywhere to other partners, if I would say. So nobody will ever know that. And instead of having it as a model that you can develop and replicate, you just stop and you get another money, you implement another one. So it's important that if we are working together or if there is a coordination between research and practice, it would be really a good thing that would even be more useful to our communities, would be sustainable, would be evident, and people to come and learn from different parts. Yeah, that's what I would say, but there is really a big gap that needs to be filled.
Okay, thank you so much. We keep talking. Maybe I may ask a Shas based on this line we are in. As you see, there is a gap, and our participant, our target population is the one we need our Rwandan community to be stable, to build our mental health, to ensure our children developed physically, mentally. Just in this partnership we are missing. What can be done? How can we do? What can we do? How can we advocate so that at least maybe the community, the policies, the NGO are working together so that maybe we can produce a sustainable things which can have a sustainable impact on child development. Thank you.
Thank you very much. I will try to reflect on your question at, I think, 3 levels. The first level is about research. The second level is about practices, NGOs, and intervention. And the second level will be this kind of partnership we are talking about. Research. Specifically for this matter of mental health, the mental health which an issue is not yet known in our context, in our culture, in our communities, even for our leaders and policymakers. Sometimes we need a little bit understanding what is it and how to do, how intervene. For researchers, I will question what kind of research do we need. Do we need the traditional research, where we produce surveys and questionnaires and just administer and just analysis? Do we need intervention research? Do we need the action research? Do we need the participatory action research? For me, I would say intervention, action, participatory action research, of course, which may include the surveys and whatever, that should be a good way of creating these networks and these partnerships. Because if we do this kind of intervention and participatory and action research, we will need, of course, practices. We will need intervention, and we will create these partnerships. I will give an example. Recently, we did a smaller project with RPS, Rwanda Psychological Society. It was a mental health, a small practice in the school. But when we engage government, RBC, now the mental health intervention is now really, if I can say politically, the Minister of Education, the Minister of Health. Now they are taking the project. Now it's officially, the mental health program is officially launched within the school system, from primary to secondary schools. So that's a kind of, if I can say, intervention, action, research and intervention. The second level, I talked about a little bit, practices. Practices, we have so good practices, the street children intervention, the MAP, the refugees. How do we do it? With who? Who knows it, as Jen was saying? Who do we engage with? I always say that we need also, as NGOs, as practitioners, as those who are creating, innovating practices, we need a little bit to engage research institution, so that they can a little bit be documented. If they are not documented, they will not be shared, and nobody will not learn from what you are doing. It will just, as Jen was saying, you do it with a small population and it's finished. You report to your donor, it's the end. But if we do engage with research institution, if even universities, if they can bring even the students just to do the intern and to do, I saw Anita, she will be presenting here something she has done in my organization with this program of street children. So that's maybe it's go beyond the practice. How can we continue to work together? And finally, the last level is about engaging other people. I gave an example of when we engage RBC, we are working with MAP at home and the MAP, and we are engaging so many hospitals when we organize online session, the in charge of mental health in those district hospitals where we are operating, they are there. Health centers, patients, and we are going beyond our small target population. Most of the time, NGOs, we just say, my target population is street children. My target population is survivors. My target population is this one. And you just, you lock yourself in a small room while you have to open it to existing structure so that they can learn, and that's how I can reflect on your question. Thank you.
Thank you so much, Shas, and you bring my mind to the question of, maybe I can ask Jenny about deprecation, because deprecation, I think deprecation it doesn't maybe benefit to the one we are supporting, and also that deprecation, even ourselves, maybe it doesn't support us like NGOs, because our target is to help, it's to have the change in the community. What do you think can be done for avoiding deprecation? Thank you.
Thank you so much. Yeah, it's all about coordination again, and working together. Say if we are in a refugee camp, I told you, we have a coordination body with the UNHCR. Then we all bring our plans. So they will know ARCTs in psychosocial work with the refugees. Maybe inclusion is in psychosocial work with the disabled or something like that. So and so is in GBV, so and so. So planning together, and sometimes even knowing the approaches. You may find the approaches are the same, but you talk them in a different language, maybe. So still people having that, maybe, because I say mine is maybe, I would say personal development, another one would say a tree of life, maybe another one would say grieving journey, or, you know. It is the same thing, but you are doing it on the same person. So you find it is really like doubling the work on the same people. One will come with healing and reconciliation, another one maybe with what and what. So there is need for coordination, and especially talking to each other as practitioners, especially us as in mental health and psychosocial support, because we are still few. It's better we talk to each other and then extend or expand our interventions to other places, or even bring together. Maybe it is this one, then the other one brings another one. So I think it is more of coordination and planning, so that if I know what you are doing, then I want to do that in the same area, because even I want to have an impact, we shall never know who has impacted the communities. Yeah, so you would rather move elsewhere. And then I think I was wondering about the policies in place. Maybe my colleagues would tell us about what are the policies in place, you know, to in collaboration of research and practice. Is there anything maybe that one could say, or yeah, I don't know.
Yes, she's going to say to reply on that. Okay. It is the same as which I have been. Who is the first? Who is going to take first step? And then is it policymakers? Is it NGOs? Is it? And you reply to her question. Thank you.
Thank you. I think we need. I would like to clarify two things: in which way academic institutions work with the communities. One way is through agreements and MOUs with NGOs, with funding institutions, with the University of Rwanda, or its other institutions like this Center for Mental Health. This is one of the examples of how you can collaborate, because this symposium was organized through collaboration between Boston College and the Center for Mental Health, for example, because there is an existing MOU and agreement. So that's one way. The second way is through grant writing for research. We do action research, we do operational research, and through these grants, we implement interventions with our own staff and students. So there is one project we did on mental health with Grant Challenge Canada, and we were addressing this perinatal depression. And we recruited these women who are leaders of women at a village level. They did not have too much to do, while community health workers were overwhelmed by interventions and trainings, and the Minister of Health was like, do not train them on mental health, because they have to work on all issues of health. So we recruited women elected at village level, we trained them, and the intervention was to provide emotional support. It's like, go around their villages and say, hello, how are you? Are you okay this morning? Nothing else. Provide no other support. Just say, hello, how are you? And this was done by women in the village, greeting pregnant women and new mothers. And after 12 months, we did an evaluation, and we found that it has made impact on the emotional well-being, on, it has reduced depression. It was different. It was a small study. It was like what they call a seed grant. And from there are many other grants that are being written between these funding institutions and the university. And we also have other initiatives funded by our university, and I believe other academic institutions have them, what we call outreach activities, where students, if, for example, they are learning about media and health, their assignment will be to develop a media campaign, and they will actually run it. Or if they're learning what I teach, community-based health interventions, I teach them behavior change theories at community level, and then we organize case studies. We go to visit NGOs, and this this is how I met Teresa Betancourt. We were in the Guinea visiting partners in health community-based interventions. And from there was that agreement. So this is an example on in which way academic institutions can work with communities, but the best way is to engage many stakeholders, as we said, and also to implement interventions. It always requires approvals and collaboration with the local leaders, with existing political structures. And so we need also to work with them and have these agreements developed and signed. Thank you.
Okay, thank you so much for great discussions. And maybe I can receive one question or concern because of much of the time, yes, so that we can hear from the participants.
Hello. So first off, I'd like to thank all of the presentation providers and the panelists for their insightful presentations. I have a question that may slightly deviate from the subject, but I also think is important in terms of implementation and intervention. So oftentimes when we are looking at scaling sustainably, we look at community members or community assistance as a sustainable way to scale up intervention. Now, in the field of mental health, this means that oftentimes these community representatives are exposed to narratives of trauma or other difficult circumstances that are occurring in the beneficiaries' households. And so I'd love to get your insight on how we could not only support the beneficiaries in terms of mental health, but how we can also sustainably support those delivering the intervention and supporting these families.
Thank you. Maybe I hope I heard the question a bit well, but the way I see, you saw about the community. All of us talk of community interventions and having community facilitators, so, trained people at community for sustainability. But what support do we give them? And maybe to their families, right? So for example, us, when we are working on that, we normally start right from the beginning to create the ownership with the local government, the local leaders. As they are selected in the communities, we involve them in a project, what is about the project and all it wants to, it will do, and what support we need from them. That is number one. Secondly, when they know they are there, they are the ones who selected them. So there is that support. When we tell them we want them, they will always call them to come. Secondly, it is more training, of course, like we do, capacity development, sometimes refresher trainings. In some of my presentation, I did peer-to-peer training where they can meet also among themselves and talk and support each other. Also, I talked about TOT sometimes where there is a strong, it depends on the level of community. If there is really these local people, we may not have them. But sometimes we have at district level where we can have TOTs. So they can go down and support them after the end of project. And part of it also, we have seen that, as you were saying, sometimes they are poor local communities also. They also need support. They support others, but say, for example, I may support someone emotionally, but I'm really very poor. I can't even send my children to school sometimes. So we also make them in groups for the small income generating. This will help also them to continue, if they have a joint activity, to continue working. We have seen it working in some places, but some places also they quarrel, if I would say. They separate and some drop out and all that. So it's not easy to work with volunteers. I think there are many models in Africa, even in the world, where they use volunteers and the model, how they support them to keep together, but it's not easy. Some drop out, others continue. We have some who even call after 10 years of 20. You know, you trained me in Changugu, I still do the work, it helped me, it helped my family, it helped, you know. I'm now a leader in this and this, I'm in school and so you find they appreciating, but others you never know if they ever trained even. So my experience is that you try to support them, you build them, you make the local authorities or the school or the environment they are in more responsible and involved. Then when you go, they sometimes remember, they always use them, for example, ours in this commemoration. They always look, where are RCT Ruhuka community workers? We need them. They make a meeting with them. They deploy them for supporting and interventions. So you find in schools the same. So yeah, I think that is my experience. I don't know if it is answering your question, but I was just sharing.
Yes, the other thing I think we have to add, we need a little bit to make ownership of the existing structures. Existing structures, if we are talking about mental health, from community health workers, health centers, district hospitals, up to referral hospitals, and engage with them and empower them. Last week I was in Nyamata with RPCA training all psychologists from all district hospitals. So empowering them, that's one. Secondly, creating, if I can say, linkages and linkages and referrals from those community members we are supporting to those existing structures. If we are talking about street children, a group in the school, how can we create a link with a health center? If the project is no longer there, there is a psychologist paid by government who can support that group. So creating this ownership with the existing structures is one of the way we use it for sustaining the program we are implementing.
For the last.
I think there is a second aspect of a question ambassador asked. How do we also support those who intervene in a sense of maybe clinical supervision, or they get even exhausted by what they do, and we are in a community with multi-trauma themselves, maybe they have their personal trauma exposure. How do we also support those who intervene plus the support to beneficiaries? I think it is the second aspect of that. Okay. So if there is any clinical supervision experience or practices.
So I wanted to talk about our experience in those community interventions I have participated in. It's the linkages between intervention implementers and beneficiaries with the existing resources. So usually when you plan at the beginning of any intervention, there is what you call community mapping of resources. And it's also part of the needs assessment and listing priorities in a given community. So if all stakeholders are involved at the beginning in those discussions of planning, and if for example, developing these grants and applying for funds, you also think of that in case to provide for services, if they exist, to link them with intervention. This is one way. But what I wanted to add also to this question was the research dissemination. Because when you invite intervention beneficiaries like parents and the local leaders, women, NGOs to research dissemination, when they come, they talk about those challenges. And if the local leaders, planners, and the policymakers are also invited. So research dissemination are opportunities to have all those dialogue and find the solutions to emerging issues. Thank you.
Thank you so much. I see there is questions. Even Jen want to have some reflection on the question, but also the time. It's very challenging. But what I can emphasize, it is better if there is way of I can call clinical supervision when the person meet with the cases and sit, maybe if there is some NGOs which is doing that even once per month, where they meet and everyone say the cases which was very maybe difficult to him or her, and it help him to release the stress and understand the others how they reply some questions. Also it decrease a little bit the way of how you are feeling. So really it's very interesting. Other who has questions, I kindly request to meet the presenters, and maybe Joseph at the end of this will share the presentation. But also don't hesitate to consult Professor Letizia, Jenny, and the Shast, so that maybe you can learn more from them or other presenters. Because even me, I had many questions. I had many questions related to the refugees, related to inclusion, humanitarian inclusion. So, but in the interest of the time, please let us go to lunch. Thank you so much and enjoy your lunch.
Thank you very much to the panelists of today. And I have a small announcement about how long the lunch will take. It will take 30 minutes.
to the room. Let me briefly talk about the third round of presentations that we're going to witness. This third round of presentations will be on early career researcher. I would like now to welcome the moderator for this session, for this round, Mr. Ririhafi Gamaliel. Could you please come forward and invite our presenters? Thank you.
Thank you very much. We are going to have 5 presenters on this interesting topic about early career research. They are all early career researchers, and I'd like to invite the first presenter, who is going to present about a topic entitled Exploring Factors Associated with Research Involvement of Undergraduate Students at UR CMHS. His name is Eric Mugabo. He's a medical student at University of Rwanda and co-founder and director of Oasis Health. I would like to invite him and give his presentation. Thank you.
Good afternoon, everyone. So I'm glad to have this time. As my colleague Gamaliel said, I'm Eric Mugabo. I'm a medical student from University of Rwanda, and I present you this study that has been carried out in our settings. So I'll go very quickly in some key findings. If you want to access on the full article, is for open access on the BMC Medical Education Journal. So as you see, it is about exploring factors associated with research involvement among undergraduate students at our College of Medicine and Health Sciences. So early involvement of research or of undergraduate students in research, it is a key in their development of their professional careers, and so much data in sub-Saharan Africa is not available currently. Yeah, because students and even other senior researchers don't dig deeper in this topic. So our study aimed at describing the level of research involvement among CMHS undergraduates and analyze or dig deeper among the factors that are associated with their research involvement. So our methodology, we did a cross-sectional study that covered the 3 campuses hosting CMHS students. We used electronic tool developed based on previous studies that were done in sub-Saharan Africa. That questionnaire was shared to students or participants through WhatsApp groups. And then by calculating our sample, it was to be 347 students. So before we started data collection, we received ethical approval from the CMHS Institutional Review Board. I can see some members of the board here who approved the study. And we analyzed our data using Stata. In the scribbing or analyzing data, p-values less than 0.05 were considered as statistically significant. Our result in the total, we got 324 students to participate in the study. So we didn't reach our sample size due to some limitations, but the mean age was 23.3. Males were more represented than females, and large populations from School of Medicine and the pharmacy, followed by nursing and midwifery. Yeah, medicine was the most frequent department, and most of the respondents were in year 3 and year 2. Few were in year 5 and year 4. 60% of our respondents think that research is important in undergraduate students or in undergraduate studies. So we used 1 to 10 Likert scale. So 60% of them graded as 10 out of 10, and then 48 of the respondents said that it is 10 out of 10, or they are very interested to take a part in research at the undergraduate level. 80% of our participants attended the research course, module, or workshop, but unfortunately, only 48% of them has involved in a given research project. Senior students will find to have involved in research than a junior student, so we consider the senior student as those one in year 4 and year 5. Of those who has involved in research, it will through URA or through a student-led organization or through another academic institution, so no student were able to have a research project on their behalf. Most students involved in data correction, involvement, study design, writing, and the abstract and the protocol writing. So many students were involved in data correction. So few were able to reach this dissemination stage where they can publish or that they can present in the conferences or symposium like this. As we continue to understand the results, understanding the research process and understanding how scientists work on problems was the most perceived benefits or skills that were acquired by students who get involved in research. And 48% of respondents reported inadequate knowledge about the research process. They also report that they lack knowledge to carry out research, they don't have funds, and surprisingly, some think that they are not qualified to do research at the undergraduate level. When students were asked what to be done to strengthen their research experience, most of them suggested the establishment of University of Rwanda Undergraduate Research Support Center, and even encouraging mentors to help or to mentor junior students. This is a figure that shows how barriers to research were. Most important barrier was inadequate knowledge about the research process, which was unfortunately the most perceived benefit of involvement. As we discuss, undergraduate students at URA are very interested in research, but their involvement is very low. So there might be something to be done to make sure that students get involved. We recommend that there might be a formalized undergraduate research support center to facilitate research activities and opportunities and competitions to undergraduate students. As I conclude, most students at CMHS are taking a part in research module course, workshop, yet students feel that they lack knowledge to research process. And some students don't think they are qualified to do research. To meet this large interest, so students must be facilitated and mentored, and the University of Rwanda has to facilitate their involvement. So thank you for your kind attention.
Thank you very much, Eric. I would like to see if there are any questions, and because I would like to receive one question, for the sake of time, I see one question, and then we proceed to the next speaker. Mr. Eric, you can come back forward to receive the question.
Thank you very much for the good presentation you have revealed to us. But indeed, we are talking about other careers such as in CMHS especially. But we have seen many students who are interested in other career research, but they are lacking skills to practice or to sharpen their skills to do some research or to get into real research. What do you think can be done to overcome that challenge? Thank you.
Thank you very much. The question you are raising is exactly the same as the question in the study. We have seen that many students, around 80% of them, are very interested to do research. But as you see, the most important barrier, they don't even know research process. They don't know what it takes to publish a study. They don't know what it takes to carry out research. So we do recommend a lot of recommendations. First of all, we recommend establishment of University of Rwanda Undergraduate Research Support Center. So we do recognize that there are some centers, including the Center for Mental Health, that facilitate research. But if you can see, most of the time, focus on the postgraduate students. There is no maybe undergraduate research grants in Rwanda. Are there any undergraduate research grants? There is none. So we recommend that there might be a such center that focuses mainly on undergraduate students. So we do also ask the University of Rwanda to organize many events like this to ensure that students get exposed to research at the early age or when they come to university. Those workshops and more trainings about statistical data analysis and the other research topics that can empower students to participate in research. Thank you.
Thank you very much, Eric. And thank you very much, Mr. Rurinda, for the good question. We cannot receive many questions. I can see. Okay, let's receive one comment from Prof. Sesvera, and then
Yes, it's just a second. I want to confirm and commit what you are saying. One, confirming that we have been involving mainly postgraduate students, and to commit that you are welcome. So you are joining the house. Make sure we keep connected and have some of your colleagues joining. I know Joseph Kalisa and Josias here and other colleagues. They will be delivering a series of workshops around doing research from the project to data collection and data analysis, quantitative. So stay with us. Thank you.
That was a burning comment I could not leave behind. We are going to the next speaker. This session is all about early researchers, and this presentation is about effectiveness of nutritional education program for school children in Rwanda, in Rwandan districts. We are welcoming Mrs. Judith Marshimana. She's a lecturer, an assistant lecturer at University of Rwanda in the School of Nursing. Welcome.
Thank you so much. I'm glad to be here to present my research proposal, which is entitled Effectiveness of Nutritional Education Program for School Children in Rwandan Districts. Go next. Nutritional disorders are observed in children, and they lead to the occurrence of the chronic disorders. Some are resulting from undernutrition, others from excessive food intake. Nutrition disorders can affect the development of children, and they also affect their school performance and their learning. The issue is very important for school children who are in their period of growth and development, whereby their mental health could be affected as well. Despite their nutritional needs, the access to necessary quality and the quantity of food is still not available. It is still limited in our development countries. So in Rwanda, the percentage of malnutrition was found to be 23% in urban communities and 45% in the Western Province communities. The National Policy for Nutrition recommended that school health program should organize activities for preventing disease and improve nutrition among school children. Those include deworming from parasite, nutritional supplements for anemia prevention, school gardens for education and nutritional purpose, and providing milk for young children. It was evidenced that nutrition education programs delivered in school can have impact on children development. Also, school-based health and nutrition program was found to be a cost-effective solution to the issues of malnutrition and disease that affect school children. So this proposal is aimed to establish educational and nutritional program in primary students. This one will contribute to improve school performance as well as the development of the children at school. Then we will follow a study that will look at the effectiveness of school health program and nutrition program in those schools to identify better approach that can be used for effective nutrition education program in school children. The first objective will to provide a health education program on prevention of nutritional disease in primary school students. The second objective will be to establish nutritional program to the primary students. And thirdly, there will be a comparative assessment between case and control group so that we measure the outcome of that program among the school children. Of course, the methodology will be to get ethical clearance and permission, etc. So we will select 2 districts, one from urban community, another from province community. We will take 2 schools from each district. One school will be a case, another will be a control. Then we will train school teachers. After they will have their round to teach children, school children, about nutritional topics. For example, they can take the food which are available in the community, like fruits or milk or vegetables. They will explain the importance of those food, and then they will help also to teach children how to prevent nutritional diseases to the children. After the session, those food can be given to those children as well. So they will be taught and they will also eat that food, so they will be somehow motivated to that topic provided. After that, this session will be provided during 30 weeks. Then student nurse can be selected to measure anthropometric measures from the children. They will measure their weight and their height, their brachial perimeter, their BMI, and the weight curve will be documented on individual files to identify association between those anthropometric measures and school performance of those children. And the marks of those children will be an indicator of those children performance. Of course, the data will be analyzed and published. Then this research will help to improve the school health system and the education program that will impact children development in our country. Thank you so much. So any question or comments are welcome. Thank you.
Okay, we would like to receive one question, and then we'll proceed to the next speaker. Any question from the audience? Okay. Maybe they are still reflecting on this topic. You can go ahead back to your seat, and we proceed to the next speaker. But as a short recap of this presentation, I saw this as a very important proposal, because we know that in Rwanda, in many developing countries, there is a big, serious issue about nutrition, and it's affecting children in the way they are educated. It's affecting children in their development. That is a very important proposal. And I see now one question coming. Is it a question? Okay. Make it quick.
Thank you. It sounds a good proposal. My concern is this: children are not the ones who make decisions about chicken or kitchen. So it's good to educate them. And another thing is, we have social determinants of health and nutrition as well. But all in all, children don't have any power in having access to food, in selecting, choosing what kind of food they will eat. So I'm asking myself, is this the right thing to do? It's a proposal, but it's also a question to myself.
Yes, I think that's a very important. I don't know if the speaker wants to react on it. Yes, give her mic.
Thank you so much. That is an interesting question. It's challenging, but it is also reflecting. As we know, children really don't have decisions on choosing their food, but they have influence at a certain level to influence their parents. I will give you a small example. If your child asks you to buy a bread, for example, even the Bible says if the children ask bread from their parents, they will not refuse them. So they may not have final decision, but they can influence. They can say, my teacher told me that this food is healthy and this food is not healthy. Instead of asking you pizza or what, maybe he will ask you milk or something which is more healthy. It is in that context that I was reflecting to that proposal. Thank you so much.
Okay, I see there are many questions rising. Let's take just one, then we go to the next. This is the last one, right?
Okay, me too. I was asking myself if this the research finding will help on how normally to the, I can say it, rural areas or whoever, they normally feed kids during the day. So now I was maybe thinking it will help on how schools are feeding their students. So now, as your research is going to help students to influence the family or to participate when the family is deciding on what they are going to feed, I would say that you have to think also on how schools are feeding kids. Thank you.
Okay. Thank you very much. We'll go straight to the next presenter. The topic is the impact of COVID-19 on parenting and childhood development in sub-Saharan Africa, a rapid review. Welcome, Dr. Ale Aishatie. He is a junior researcher at University of Rwanda. Let's give him a floor.
Thank you so much. Good afternoon, everybody. This study coming from the knowledge, the caregiver mental health knowledge sharing series. So it is among other studies done to review what is the impact of COVID-19 on parenting and child development in sub-Saharan Africa. So, you know, COVID-19 protection measures included social distancing, hand washing, business closures, ban on social and religious gathering, lockdown, mandatory quarantine, and isolation. So all those measures has had psychological effect, including feelings of stress, uncertainty, despair, generalized anxiety, fear of getting infected or infecting others. So our review showed some commonalities about caregivers experienced heightened mental stress, loss of livelihood, financial hardship, difficulty accessing healthcare, and medication food insecurity. So the World Bank estimates that people living in extreme poverty will increase in sub-Saharan Africa region from 37. It is critical to build enhancements to social and cultural resilience factors and coping mechanisms in preparation for future school shocks. So among our objectives was to further understanding and document the mental health needs of primary caregivers and children during pandemic globally, and to highlight the need for proper advanced preparation to strengthen resilience of caregivers and children during pandemic, especially in sub-Saharan Africa, and at the end to suggest improved tracking and measurement to document any stagnation or losses to the historical progress gained in maternal health and well-being and early child growth and development. So this is the conceptual framework informing our review, and our outline discusses the impact of COVID-19 on the following: access to health services, economic status of caregivers, emotional well-being of caregivers, parenting, and child development. So about access to the health services, you know, women fear being forced into quarantine and even being separated from their babies immediately after delivery. That's why women delay going to the hospital until very late in the delivery period, resulting in high risk of medical complications and more poor outcomes, including stillbirth, neonatal, maternal death. So after delivery, COVID-19 positive women were separated from their babies from 14 days. So breast milk was expressed and sent to the baby, which impaired the very important early attachment process in the first hours. So there was also economic impact, and there was also emotional impact with an increased rate of intimate paternal violence and gender-based violence. So, And we know that studies document that poor nutritional status of children for whom caregivers who are depressed as a result of intimate partner violence. So about parenting, so with the increase of maternal depression during the COVID-19 period, the caregiving ability is impacted, including exclusive breastfeeding and the positive interaction bonding between mother and child, leading to delayed growth and developmental milestone of children. So there was also a positive income from this pandemic, because we had the opportunity to have male to be engaged also. So as a recommendation, I see the time is rushing. So finally, I would like just to invite the government, policymakers, and NGOs to prioritize development and strengthening of early child development programs and policies, which extend beyond education to include child education, child protection mechanism, responsive caregiving education support, and remote options for early learning support to pre-primary age child and their caregivers. So these are many references I went through during this rapid review. Thank you so much for your attention.
Thank you very much, Dr. Ale. He's a medical doctor, I forgot to say that, pediatric doctor. Yes, he's a pediatrician by training. I would like to see if there's any question, then we receive the question, he will quickly address it, then we proceed to the last speaker in this session. Do you have any question? Okay. Or comment?
Yeah, thank you, Dr. Alain, for your presentation and sharing with us this information. I have one question. During your review, did you find any literature or evidences that support the argument that domestic violence has increased during the COVID and in turn to affect the family functioning, child rearing, and child protection? Thank you.
Thank you so much, dear Professor, for this question. Yes, in the literature review, there is a study done by Alain Dendy. And they show that in Africa, especially in Congo, Burundi, and Tanzania, the country in sub-Saharan region, they have been an increased rate of gender-based violence, and people didn't call police or to ask for support. And so it was just an hypothesis that this should impact, if we know the impact of gender-based violence to the families, it was just an hypothesis that we can have an increased rate also on children with disabilities or children in the early age should not have adequate responsive caregivers due to, and should be also exposed to toxic stress at home. So it was just an hypothesis about the impact. But for sure, they find that in this region there is an increased rate of gender-based and violence.
Thank you very much, Dr. Ale and Prof, for the question. I would like to go to the next session because the time allotted for this session is already over. Maybe we can ask this question because it'll be in the next panel. We can pose this question during this panel. I'd like to receive the next presenter, she's a young researcher as well, a clinical psychology student at University of Rwanda, soon to graduate, and she's a research assistant. She's going to present on the relationship between parenting styles and conduct disorder in childhood, a case study of street children reintegration by Usengani Manzi. Her name is Mrs. Wasesenda Kizanita. Let's give her the floor.
Good afternoon. I hope you're all well. It's kind of tricky presenting in a few minutes, but I hope I capture the important parts of the study. This is a study I conducted for my final project of undergraduate studies, and as Lilihafi just said, it is entitled The Relationship Between Parenting and Conduct Disorder. So just a run through, I think Shast was here earlier and he talked about the programs they have, and in those programs, the one I focused on was the one that reintegrated street children back into schools and back into their homes. And I will remind you that conduct disorder is defined as a repetitive, persistent pattern of behavior whereby a child or an adolescent doesn't go with the normal norms, the societal norms, or can even let others not be safe when he's around. So just a quick run through of the literature that has been going around. The global burden of disease in 2010 recorded CD to have a prevalence of 3.6 in males and then 1.5 in females. And other epidemiological studies with the most focus in North America and Europe estimated CD or conduct disorder to have a prevalence of 3.2 in children aged 6 to 18. We see also a report, a recent report of National Children's Commission reporting the numbers of street children being on the rise, yet most of these children, when they go into rehabilitation centers, they're given the diagnosis of conduct disorder. So if all the reports that you are seeing are true, that means Rwanda is having an increase in conduct disorder. So this research had an objective of exploring parenting style, interaction between child and child development results, and to explore the risk factors around conduct disorder. And I asked myself before starting the study, what would be the role of parenting styles in conduct disorder development, especially in street children, as well as the factors that related conduct disorder to street life, and what could we define as conduct disorder in our context as Rwandese. So the methods I used, it was a qualitative approach, and we chose 5 participants, the parents of street children that had gone through reintegration at least once by Usengani Manzi, and I used a self-constructed interview guide and also a disruptive behavior disorder rating scale, as well as a parenting questionnaires. The two, apart from the interview guide, were going to help me to understand the parenting styles of the parents present, as well as to know if the kids that were involved in the study really had conduct disorder. And so my results, these are the demographics, but even from the demographics, some of the risk factors of conduct disorder emerged. Like 80% or 4 of the parents that were present in the study, they either had separated or divorced or had marital discord. And they also, 40% of the parents or the households present had a large family size of more than 6 children, yet being parented by one parent. And also 60% of the participants were unemployed, so that leading to a socioeconomic disadvantage. So on the test results, 4 of the children qualified to have conduct disorder, and the symptoms they had were more related to aggression. And then in parenting styles, the parents scored as authoritative parents. I just want to go quickly before the minutes are over to what emerged from the semi-structured interviews. These are the themes that emerged. And under those themes, generally the parents perceive street life as something unpleasant and they wouldn't wish their kids to remain with that. One even said that it feels as if it's ichasha, or the kid is marked for his whole life, even if he no longer is a street child. And also they enumerated some of the risk factors that they felt made the children go away, which are single parenting, urbanization, and other things. And then the second theme that emerged was suffering. Suffering was not for the children on the streets only, but also their parents. And one said it's a sickness that exceeds the parents' ability to handle it, and even goes to the children, making them go away. On parenting styles and child outcomes, the parents enumerated their roles as parents, but also they another major role they said was protecting the children from destroying their lives, what they called in Kinyarwanda kwandavura. And these are some of the definitions they gave to positive parenting. I think my time is up. I'm remaining with one theme. So, as I told you, these parents had either gone through reintegration process or attended at least one session, and they showed that their kids' behavior kind of changed. Some even said, my child approaches me to talk to him these times, or he wants to go to school when at first I was the one who used to force him to. And I think I'm done. I would recommend, in my recommendations and conclusions, I was encouraging psychological firms to invest in prevention and more research to be conducted on this, on parenting and childhood behavior outcomes. I think that's it. Thank you very much. Questions?
Yes, let's receive questions. One question.
Any questions? Yes.
Okay, there's one question.
I'm Dr. Agustin of Clinical Psychology. I would like to ask to go back before conclusion, before recommendation. Yes, there, for example, when you said parental management training and rehabilitation impacts, 1 and 2 and 3, what are those impacts? For example, is it better to go through life stories to nominate at least a title and another title and another title to help listeners or readers to get aware of what are those impacts? For example, it is an advice for you as a junior researcher, not only to present life stories, but to show the reader or the listener what are those impacts. You use your mind to go through those stories, life stories, and to find a real word. It is only an advice. It is not a question.
Okay.
Yes. Can you go?
first impact, rehabilitation impacts, or management, I know. What do you mean by life story? What do you conclude among those life stories? What is the first, what is the second, what is the last, the third? Because only reading life story is not enough for us. Do you understand my question?
I'm not sure if I understand, but you were saying, I think through what the narratives that they gave to me and then summarize that as impact?
Yes, for example,
Okay.
number one, you can say, go back again. You can say counseling, the role of counseling. Do you understand? Yes. Go back, number 4, for example, positive parenting. What do we extract from those life stories to help us to understand? Ni uburyo buzadufasha kumva ko wowe nk'umushakashatsi utagendera gusa kuri life stories ngo uzikopiye, ahubwo wavanyemo iki muri izo life stories. What is behind? Ni iki psychologically cyangwa se your mind yavanyemo kugira ngo utubwire uti positive parenting is composed by this and this and this.
Okay.
Do you understand?
I understand.
Yes.
Okay. So navuga ko nari nakoresheje in terms of presenting quoting, like using literal quotes zibyo bavuze, and then I understand ko the next is to like summarize and get the whole picture. Yes. Is there any other question or comment?
Yes. Any comment?
My comment is this. I think today we had 2 students. I know you are yet to graduate. 2 students presenting in this symposium, which is something we do really appreciate. It is a capacity building symposium. Junior students, they were genuine in presenting. We want to have more to come. That's one. And the second, from this presentation and what was done by the colleague, Dr. Vianney,